So welcome everyone to meeting number 29 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the COVID-19 pandemic. I would like to welcome the Honourable Patty Hajdu, Minister of Health, and the Honourable Anita Anand, Minister of Public Services and Procurement. I'd also like to welcome senior officials joining us today. From the Department of Health, we have Dr. Stephen Lucas, Deputy Minister. From the Canadian Institutes of Health Research, we have Dr. Michael Strong, President. From the Department of Public Works and Government Services, we have Mr. Bill Matthews, Deputy Minister, Mr. Michael Vandergrift, Associate Deputy Minister. And from the Public Health Agency of Canada, we have Mr. Ian Stewart, President, Major General Danny Fortin, Vice President, Vaccine Rollout Task Force, Logistics and Operations, Dr. Teresa Tam, Chief Public Health Officer, and Dr. Matthew Tunis, Executive Secretary from the National Advisory Committee on Immunization. We will start with member statements, witness statements. I will invite Minister Hajdu to begin. Minister Hajdu, please go ahead. 7 minutes, please.
Thank you very much, Mr. Chair, and I'll just give my remarks in English to go easy on the translators given this virtual environment, but I will say that I'm very happy to be here with you all and thank the committee for the opportunity to share an update on our work to protect Canadians against COVID-19. And of course, many people have used the word unprecedented to describe this pandemic. In fact, around the world, we've talked about the unprecedented nature of a global pandemic of this sort. But it is also, besides unprecedented in its scope, it is obviously unpredictable as the virus has changed and shifted and as we've attempted to keep ahead of our knowledge of how best to protect people from COVID-19. And of course, as we see case numbers rising across the country, Canada and indeed the world have worked hard to manage COVID-19 and protect our citizens in each of our jurisdictions. Every step of the way since January 2020, our government has responded to and adapted to information as it has evolved. And information is coming to us in real time. On many fronts, we learn as we go, and I want to take a moment to thank the scientists, the researchers, the public health officials who have worked nonstop to better understand this virus, to better understand measures to protect against this virus, and to better understand how it's affecting the many communities in our country. And Mr. Chair, I think it's important to establish that context as we address the important questions before us today. All levels of government are racing to ramp up vaccination, to suppress the rapid spread of variants of concern and indeed the virus itself, and to help bring the pandemic under control. As of April 16th, more than 12 million vaccines have been distributed to the provinces and territories, and we've delivered over 10 million doses by Easter weekend, which exceeded our initial goal of 6 million doses for the first quarter of this year. And as of now, more than 9 million doses of COVID-19 vaccines have been administered in Canada. 81% of people 80 years of age and over have received their first dose, and 10% have received both doses. The Government of Canada is going to continue to do our job to make sure that more and more doses are delivered throughout the country. And we will also be there for provinces and territories for any additional support or resources as they might need it. We're also going to continue to provide advice to Canadians about vaccination and about how to protect themselves against COVID-19 as we see the virus accelerate in many jurisdictions across the country. We work with real-time data, and Health Canada carefully reviews any new information that becomes available so that our advice continues to evolve and be based on the best and latest science. As the vaccine rollout continues, we continue to work with partners in industry and the not-for-profit sector to increase testing and screening capacity across the country. Testing and screening continues to be at the foundation for slowing the spread of COVID-19, although of course it's very important that provinces and territories also manage people well and in a supportive way who have tested positive for COVID-19. Mr. Speaker, it's important to know if people are sick, and it's important to support them when they are, and that's the best way to stop the spread of COVID-19. On testing, as of April 8th, 2021, more than 25 million rapid tests have been shipped to provinces and territories. 25 million, Mr. Speaker, Mr. Chair. Keep calling you Mr. Speaker, but take the role. When combined with the federal allocation, over 41 million rapid tests have been distributed across the country. And not only have we delivered those tests, we've also been working with provinces.
Excusez-moi, Monsieur le Président.
Excuse me, Mr. Chair. I apologize to the minister. I really apologize. But there's a problem with the sound here in my office. The issue is that even though I'm on the French channel, I'm also hearing the minister very loud at the same time as I hear the interpretation. So it's impossible. I only have 2 ears. I don't have one for English and one for French. So I'm not able to understand correctly what's being said. So I don't know what the procedure would be. I know I've already had that problem. Something similar has happened before, and I disconnected and I reconnected, and that allowed me to resolve the problem. I suggest that I do that. And in the time that it would take for me to get back, I hope I won't have missed out on too much of the minister's speech, or perhaps you could wait for me to reconnect. What is your decision, Mr. Chair?
Monsieur Thériault.
Thank you, Mr. Thériault.
Nous attendrons.
We will wait.
Ben, briefly, while Mr. Thériault fixes his problem. Rempel Garner, we'll do the best we can all the way through here. Mr. Thériault, thank you for bringing up the problem, and it is very important that you do so, as and when, as soon as it happens. So, do let me know if the translation is working correctly now. If you can, give me a thumbs up. Perfect. Okay, Minister Hajdu, thank you for your patience, and would you please start again?
Mr. Chair, point of order. I think that we've waited, it's a lot of time. So I'd look to Mr. Thériault if he wants the minister to restart or just continue her remarks, because I think we'll lose 2 rounds of questions if she restarts her remarks and doesn't stay.
On poursuit.
We can continue, Mr. Chair.
Very well. I understand you want just to continue from where the minister left off. That's acceptable, I believe, to the committee.
Yes.
Very well. Thank you, Minister. Please do continue from where you left off, if you can.
All right. Well, I will. I'll begin at the testing section, and talking about testing. As the vaccine rollout continues, of course, it's important that we continue to test and contact trace and support people who have been infected with COVID-19 to isolate, to contain the spread of the virus. As we do that important work together, of course, the government has been working with partners in industry and in the not-for-profit sector to increase screening and testing capacity across the country. As of April 8th, 2021, more than 25 million rapid tests have been shipped to provinces and territories. And when combined with the federal allocation, over 41 million rapid tests have been distributed across the country. And we've supported the provinces and territories along with the private sector to ensure that rapid testing can help identify the spread of COVID-19 in essential workplaces and in congregate living settings. In fact, Mr. Speaker, in pandemic spending, in fact, 8 out of every $10 spent on our national response has come from the federal government. Recently, the province of Alberta announced that more than 2 million rapid tests will be available for businesses in Alberta. And this is an expansion of a program that's already successfully rolled out more than 1.2 million rapid tests to long-term care facilities, schools, hospitals, and homeless shelters. In this next phase of Alberta's program, test kits will be provided to employers and service providers with priority given to organizations that work with vulnerable people. And this will give employees that sense of security and comfort when they go home to their families at night after working with the public all day. Mr. Speaker, there's no silver bullet to fighting COVID-19, but adequate rapid testing, along with appropriate contact tracing and isolation, are layers of protection to keep essential workers safe as they stay on the front lines for all of us. From border measures to mandatory quarantines to digital tools to the establishment and funding of safe isolation sites, the Government of Canada has been working with provinces and territories every day to keep Canadians safe. And we're going to continue to use all tools at our disposal to help this country through the pandemic. We will do whatever it takes for as long as it takes, Mr. Speaker, to protect Mr. Chair, to protect Canadians. I would like to conclude with a few words about the report recently published by the Office of the Auditor General of Canada. As you know, it raises issues concerning the Public Health Agency of Canada's response to the emergence of COVID-19. Now, we've accepted every recommendation from this audit, and work is underway to respond to these recommendations. We have to keep the health and safety of Canadians as our top priority across government. That's why the Government of Canada has provided significant funding and resources. As I said, 8 out of every $10 in the pandemic response has come from the federal government. And this includes recently $690.7 million in the fall 2020 economic statement to strengthen the Public Health Agency of Canada's response and surge capacity. I will say that the agency has grown tremendously and has expanded by more than 1,000 new employees to bolster our capacity to have more people able to support and protect Canadians across a number of areas. And the agency continues to grow to support our response to COVID-19. In October, the agency implemented a national COVID-19 public health data portal to support data collection, sharing, and management, something that we know we need to get better at all across the country. And I've asked for an independent review of Canada's global public health surveillance system, commonly referred to as GFIN, and a final report and recommendations is expected later this spring. These measures will help us improve Canada's pandemic preparedness and response capacity. Mr. Chair, whether it's financial supports for Canadians through the CERB, the CRB, wage supports for businesses through the CEWS, wage top-ups for healthcare workers, and through my portfolio, things like safe isolation sites for communities, Canadian Red Cross personnel, field epidemiologists and other experts, contact tracers, mental health supports, free and directly deliverable to Canadians through Wellness Together, along with $19 billion through the Safe Restart Agreement, the supplies and resources fully paid for provinces and territories to test, track, and treat COVID cases, treatments for COVID-19, millions upon millions of vaccines. Every step of the way, Mr. Speaker, we have stopped at nothing to support provinces and territories to deliver on their responsibility to provide healthcare to Canadians in their jurisdictions. And as we see this third wave threaten so many lives, we know that we have to keep working together. All hands on deck, Mr. Speaker. This is a Team Canada moment. We have to keep working together and working with our partners because Canadians want us to do that. They need us to do that. They need us to continue to be collaborative, to look for ways to help. They want us to know that they need us to work together and that we are going to get through this together. So to my colleagues here today, I hope that you will use your platforms, your ability to communicate as leaders in your communities to encourage Canadians to get tested, to stay home when they're sick, to wear face masks, to isolate when they're close contacts, to restrict their movements, and indeed to get vaccinated when it's their turn. It's very important, Mr. Chair, that we are all speaking from the same page on this. Thank you very much. I look forward to your questions.
Thank you, Minister. We'll go now to Minister Anand. Minister Anand, I would invite you for up to 7 minutes for a statement, please. Go ahead.
Thank you so much, Mr. Chair. And I want to thank the committee for inviting me to speak here today and
Excusez-moi,
answer.
Monsieur le Président.
Excuse me, Mr. Chair. I'm not hearing the interpretation correctly. Between the interpreters, there seems to be a volume issue. It's not the first time it's happened, but when the interpreter changes, the volume isn't at the same level. It seems that attention should be brought to this. The problem is, if I raise my volume, as I do, then when the other interpreter takes over, then I have a real issue with my ears. And I've been doing Zoom over a year and a half, and it's taking its toll. So I'd like for that remark to be taken into account, because it's not just about the interpreter's hearing, it's also mine in question here. Thank you very much.
Merci, Monsieur Thériault.
Thank you, Mr. Thériault.
I do notice myself that when the language switches to English, that there's a lag between when the volume is restored. So let us forge ahead. Please do keep us informed, Mr. Thériault, and we'll do the best we can do. Okay. Minister
C'est pas réparé, Monsieur le Président.
It hasn't been fixed, Mr. Chair. I don't want to increase my volume to a level that would be dangerous for my hearing. The problem hasn't been resolved, and I think it's in the booth that the problem needs to be addressed, and the clerk needs to send instructions right now, because I have 3 hours to spend with you, and I don't want to deal with this during 3 hours. So I would like for the problem to be resolved. I'm sorry, it's unfortunate, but that's what I'm dealing with and what I've been dealing with for a year and a half. Thank you.
Thank you, Mr. Thériault. We will suspend briefly, and I see the clerk has gone to talk to the people in the booth. So we will suspend briefly. Thank you. Thank you for your patience, everyone. Translation is sometimes difficult. And anyway, I would invite Minister Anand to, I guess, resume. You've actually just started your statement, so maybe just start from the beginning again might be the best thing. So please go ahead.
Well, thanks so much. I was just actually thanking everybody for having me here, and I look forward to taking your questions. And I also wanted to thank the translators whom I know have been working so very hard during this whole pandemic and various committee meetings. I would like to also acknowledge that I'm meeting you from the territory of many First Nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Je comprends le sentiment d'urgence.
I understand the sense of urgency in which this meeting was called. The government is facing this crisis and has been for over a year. Canada is now in the third wave of the virus, Mr. Chair. And since the beginning, my department, Public Services and Procurement Canada, has worked 24 hours a day.
In English, we're now getting the translation and the original text or the voice at the same level as well. I wonder if we could have the translators take a quick look at that, and please carry on, Ms. Minister.
7 jours semaine pour
7 days a week to purchase the goods and services necessary to allow Canada to get through the pandemic.
At PSPC has been to meet the needs established by the Public Health Agency of Canada and Health Canada as they worked and continue to work with the provinces and territories to support Canada's healthcare professionals on the front lines. Early on, we focused on buying urgently needed PPE in what proved to be a hyper-competitive global market with huge international demand for a finite supply of goods. My team accelerated procurement processes and in some instances established completely new international supply chains to ensure that Canada had access to the most vital PPE from overseas as well as right here in Canada. Indeed, we tapped into the ingenuity of Canadian companies. We put in place contracts with those who answered our call to action and stepped up to deliver what they could. De plus, notre gouvernement a fait des...
In addition, our government has made significant investments in national production of PPE, which we sorely needed by helping many Canadian businesses convert their supply chains. To date, my department has provided 2.5 billion pieces of equipment, which we are continuing to receive, with a substantial amount of that equipment being made right here at home. We have also procured other vital supplies and services on behalf of the Public Health Agency of Canada, such as rapid tests and medical equipment.
Of this committee well know. Our focus now is on vaccines, getting them into Canada and into the arms of eligible Canadians as soon as possible. We are also supporting the Public Health Agency of Canada and all provinces and territories with the supplies necessary, including the low dead volume syringes. Moving to vaccines then, Mr. Chair, our work from the outset has been to follow the advice in our procurements of the Public Health Agency of Canada and the COVID-19 Vaccine Task Force. On their advice, we began by building a diversified portfolio of vaccine candidates as soon as they began to show promise and as soon as we received the advice of the Vaccine Task Force, signing agreements in principle with potential suppliers as early as July 2020. Notre objectif avait été de placer le...
Our goal was to put Canada in a solid position to obtain doses as soon as vaccines were deemed safe and effective, and that's exactly what we have done. We gained access to more than 400 million doses of potential vaccines from 8 different manufacturers, resulting in one of the most diverse portfolios in the world.
Leo is giving Canadians some security in what continues to be a volatile marketplace for vaccines. And it is thanks to this diverse portfolio that we are seeing inoculations happening across this country. We have 4 approved vaccines. We have received more than 12 million doses in this country since December. Millions more are arriving on our shores every week. We're working directly with our suppliers to keep them coming. At the same time, we continue to negotiate for earlier deliveries from vaccine suppliers. Indeed, the Prime Minister and I just announced that we have secured the delivery of an additional 8 million Pfizer vaccine doses. The first 4 million additional doses are scheduled to arrive in May. That's 2 million doses a week in May coming to Canada. That is double the amount of Pfizer doses that we previously had expected. And indeed, in June, we will also see more than 2 million doses arriving per week in June. And then in July, 2 million more doses. So, Mr. Chair, Pfizer has really stepped up in order to ensure that we get vaccines into Canadians' arms as soon as possible. All of this means that from April until the end of June, we are set to receive at least 24.2 million doses of Pfizer, and by the end of September, Canada will have received 48 million Pfizer doses. This is in addition to the other shipments of vaccines that are coming in from Moderna, from AstraZeneca, and from J&J. C'est une excellente nouvelle pour les Canadiens.
This is tremendous news for Canadians. It means more Pfizer vaccine doses sooner, on top of the millions of other vaccines we already have coming. I can also now provide an update on our anticipated deliveries of Johnson & Johnson's vaccine.
Shipment of approximately 300,000 doses during the week of April 27th, with more substantial deliveries coming in the latter part of this quarter and into the third quarter. For AstraZeneca, Canada is scheduled to receive 4.1 million doses from various sources by the end of June, with further deliveries in the third quarter. In total, prior to the end of June, Canada will receive between 48 to 50 million doses of vaccines. Mr. Chair, as we've said many times, by the end of September, we will have more than enough doses so that every eligible person in Canada will be able to be fully vaccinated. Encore une fois, c'est une bonne nouvelle pour...
Once again, this is good news for Canadians, but it doesn't mean our work is done. Our government continues to work with suppliers and our international partners to ensure the steady flow of vaccines into this country. And we are continuing to push for earlier delivery of vaccines from our suppliers.
It is the most important work that I have ever undertaken in my professional career. But like many of you around the table and Canadians across this country, I am worried about the third wave, and I am working
Pardon me,
as hard
Minister.
as I can to bring vaccines into this country as soon as possible.
Pardon me, Minister. I don't know if it's your microphone or whether it's generally heard the same, but I heard probably the last minute of your remarks were very choppy, very, very staticky. Was the committee able to hear those the final remarks?
Okay, Chair,
yes.
I move that the committee now proceed to questioning rounds.
We have an agenda, and we now have invited the other witnesses to give statements as well. We'll continue on with those.
Point of order, Chair. If there's a motion on the floor that needs to be dispensed with.
There's not a motion on the floor. You cannot make a motion on a point of order.
I didn't move a point of order. You acknowledged me without me saying point of order.
In any case, we will carry on with the agenda as
challenge the ruling.
Okay. The question is, shall the decision of the chair to carry on with the agenda and the witness statements as requested be sustained. Mr. Clerk, if you would please conduct the vote.
Ms. O'Connell.
Yes.
Mr. Kellaway.
Yes.
Mr. Polowski.
I'm assuming we're voting whether to continue on with the agenda with the other speakers. If that's the case, then yes.
Ms. Sidhu.
Yes.
Mr. Van Bynen.
Mr. Chair, we probably would have enough time to resolve the issues if we weren't having all these interruptions. I vote yes.
Mr. Dreeshen.
No.
Mr. D'Entremont.
No.
Mr. McGuire.
No.
Ms. Rempel Garner.
No.
Monsieur Thériault.
Non.
Mr. Davies.
No.
Yeas pour 5, nays contre 5, nays contre 6.
Very well. The committee has made its decision. We will not carry on with the statements from the other witnesses. We will therefore start with our round of questioning. We'll start with the Conservatives. I expect that would be you, Ms. Rempel-Garner?
That's
Go
correct,
ahead.
Chair.
Okay.
Thank you, Chair. My question, I'll start to Major Danny Fortin. How many doses of Moderna vaccines will arrive in Canada between today and the end of the month of April?
Thank you, Mr. Chair. 650,000.
How many doses of Pfizer vaccines will arrive in Canada between today and the month of April?
Between now and
between today and the
end.
end of 2 million. Okay. How many doses of Moderna vaccines will arrive in Canada between May 1st and May 15th?
I do not know this time, Mr. Chair.
Okay. And how many doses of Pfizer will arrive in Canada between May 1st and May 15th?
From May onwards, Mr. Chair, we expect 2 million a week approximately.
Okay, and that's been confirmed, so there'll be 4 million Pfizer doses by May 15th. Between May 1st and May 15th.
2 million a week, every week. Yes,
Okay.
Mr. Chair.
All right, thank you. To Mr. Tunis, when do you expect to reach a decision on whether to change NACI's recommendations on the use of the AstraZeneca vaccine in persons under age 55?
Thank you for the question, Mr. Chair. So the National Advisory Committee on Immunization, or NACI, has been meeting this week to discuss the evolving situation and the conclusion of Health Canada's assessment. And they are working very quickly to try and update any recommendations on that to provide advice to the Government of Canada and to provinces and territories. We would expect something in coming weeks from the committee.
How many weeks on that?
We likely next week. The committee is working
you.
right now to deliberate. Thank you.
The United States, as well to you, Dr. Tunis, the United States has paused the distribution of the Johnson & Johnson vaccine. Is NACI preparing similar advice for Canada, or will the rollout proceed under current advice as scheduled at the beginning of May?
Thank you for the question. NACI has not yet issued advice on how the Janssen vaccine should be integrated into public health programs in Canada. It is authorized, of course, in the country, but the committee has been deliberating and has been waiting as more information comes forward. We've seen the evolving situation in the US, obviously. So the committee has been discussing the Janssen vaccine and is expecting to provide advice before doses arrive in the country. So they are moving to provide us advice this month. That's the expectation from the committee, but we don't know at this time what the conclusions of their deliberations will be and where they would see to fit Janssen into the public health programs recommended to provinces and territories. Thank you.
When will that advice be ready?
So, Mr. Chair, the advice would be ready. They're working on it now. And before the doses arrive, so before the end of the month, is the expectation for the committee.
Thank you. To Minister Haiju, has the federal government made a formal request to any other country or aid organization for critical care workers in the event provinces request surge capacity in coming weeks?
Mr. Speaker, we work really closely with provinces and territories on their anticipated health human resource requests. And I will turn to Deputy Lucas to talk about those conversations he's having with other deputy ministers across the country.
Deputy Lucas, the question was as follows. Has the federal government made a formal request to any other country or aid organization for critical care workers in the event provinces request surge capacity in coming weeks?
Mr. Chair, I would note that we are in discussion at the officials level with provinces in terms of anticipated needs, both for health, human resources, medical equipment, and other supplies. And on the basis of those, we'll address them in terms of federal assets and supports from other
Deputy
provinces.
Lucas, have you asked any other country or aid organization for critical care workers?
No, we have not, Mr. Chair.
Thank you. Deputy Matthews, Reuters reported that deliveries of Moderna COVID-19 vaccines are on track to meet the number of doses that promised the European Union this month, but that there's no disruptions. That is, that there's no disruptions for the European Union, yet Canada has seen its supply of the vaccine disrupted from the manufacturer. Was there any form of remedy negotiated into our contract with Moderna if they miss a quarterly delivery target?
Thank you for the question, Mr. Chair. The deliveries by quarter from Moderna, Pfizer, and all other vaccine companies are targets, and we're working with Moderna to make sure that they do their best to meet the Q2 target. And we are aware that Canada and some other countries are having a dip.
So they're targets. They're not firm delivery requirements in the contract at the end of the quarter.
Mr. Chair, I'm not going to speak about the confidential nature of the contracts.
Well, you just said that they were targets. So is there a difference between target and firm contractual obligations?
I'm sorry, Mr. Chair, I can't elaborate more on that at this stage.
Was any form of remedy negotiated into our contract with Moderna?
Again, Mr. Chair, I'm not going to elaborate on the confidential nature of the contracts at this stage. We are in discussions with our suppliers about taking some transparency measures related to the contracts, and that
Thank you, Chair. With that, I will put the following motion on notice. That in relation to the committee's study on the emergency situation facing Canadians in light of the COVID-19 pandemic, that the committee do summons Patricia Gauthier, Canada Country Manager for Moderna, to appear and testify by April 30th, 2021 for no fewer than 2 hours. Thank you, Chair. That concludes my questions.
Thank you, Ms. Rempel-Garner. We go now to Mr. Kellaway. Mr. Kellaway, please go ahead, 6 minutes.
Thank you, Chair, and hello to the ministers and the rest of the witnesses. Thank you for coming today. My questions, my first round of questions will be focused on Minister Hajdu. So, Minister, as Canadians, we're fighting this virus together. I believe that COVID-19 is not a political war. But I think we should look to other provinces and territories to learn what has worked and what hasn't when it comes to keeping Canadians safe from the virus. Here in the Atlantic, the provinces banded together early on to tackle COVID-19, and our premiers truly took an Atlantic approach, team Atlantic approach. So I'm wondering, in your opinion, why has the Atlantic region been so successful in slowing the virus?
Well, thanks very much, MP Kellaway. And it really speaks to the different experiences that provinces and territories have had. And I have to say, it's been a pleasure to work with all the health ministers from the Atlantic provinces who have been extremely supportive of the other provinces. And even recently, the ministers and Premier of Newfoundland suggesting that they would be there for Ontario. And you're right, this demonstrates that I think provinces and territories acknowledge that we are really in this together, and no Canadian is safe until all Canadians are safe. I think one of the things that I've really noticed with the Atlantic provinces, and really speaking bluntly, is those provinces did not wait to take action when there were outbreaks in communities. In fact, the measures they imposed were it probably felt very stringent as an Atlantic member when there were potentially very few cases, 5 or 10 cases in some cases of these outbreaks. But these premiers and health ministers made a decision to act very quickly on very few cases and to do that really hard work of contact tracing and isolation. And the population themselves understood that even though they were few in number, that it was better overall to make a collective sacrifice to keep the region safe. I think there's been a real focus on protecting and supporting people who are sick and isolating them appropriately so that they can indeed stay home. It seems easy to say to people, stay home when you're sick, but isolation is actually really challenging. You can't leave your house. You cannot leave to get groceries. You oftentimes, if you don't have internet or digital access, are cut off from the world. And of course, if you're single or living in poverty, there are other barriers. And, you know, when I think about the East Coasters and the way that they band together in general, it's a real true testimony to working together in collective action to fight a significant threat.
Thank you, Minister, for that. I appreciate it. I'm going to switch gears just a little bit. People around the world, within our country, are everyone. We're eager to get vaccinated. Everyone is eager for this pandemic to end. And my heart goes out to many in Canada and many of the hotspots in Canada. Yet, you know, we hear stories though, and misleading claims, variety of misleading claims that these vaccines can't be trusted or can't be safe because of the speed with which they were developed. Now, what do you have to say about those promoting vaccine hesitancy? Quite frankly, and I know it's $1 million question, but how do we combat that? We've talked about it in previous health sessions, but you know, I continuously see it on social media, and I see it in different forms of social media. How do we combat that, and what do you say about that?
Well, thank you very much, MP Kellaway. And I'll just say that vaccine disinformation is not new. We've seen anti-vax types of information and disinformation sown in communities around other health threats, and it does lead to loss of life, and it does lead to great suffering. Many of you will have met Jill Primelli in your travels as MPs, and she's a woman who lost her very young child to influenza and has been advocating for people to be immunized against the flu for years. And so when you hear those stories, you realize this is not specific to COVID-19. Of course, these vaccines were developed in record time, and it's really a testimony to the coordinated will and determination of science and researchers really working together on a common goal. It's important that Canadians have access to credible sources and are pointed to credible sources. I always say that people who are hesitant or unsure, the best source of information for them, if they have one, is a personal healthcare provider. And then, of course, healthcare websites that are government run and credentialed as such. And, you know, of course, part of it is our responsibility as leaders to make sure that we're pointing the people that trust us in the right direction, and that we're not giving messages that are meant to sow division and distrust, but rather to give people access to accurate information so they can make the best decision for themselves, but with a foundation of credible information. It isn't about trying to force people to accept vaccination. It's about making sure they have the right information and credible information. And I'll end with this, MP Kellaway, because I think it's important. The risk from COVID-19 far outstrips any risk from vaccination. We know this, and I think if you allow me, MP and Chair, I'd love for Dr. Sharma to talk a little bit about the technical end of what goes on from Health Canada to make sure these vaccines are indeed safe.
By all means.
Dr. Sharma?
Mr. Chair, perhaps I'll speak. Dr. Sharma's not a witness on the panel this afternoon. But Health Canada has a very rigorous independent regulatory organization. It has very high standards for safety, quality, and efficacy. We did publish our standards for those in the fall, and they're aligned with other leading regulators. The review process involves teams of scientists from a variety of disciplines. We put in place an interim order to accelerate the reviews without sacrificing any of the intense scientific analysis required to evaluate the vaccine submissions relative to those standards. This was enabled through a process of rolling review, being able to look at the submission as it was provided, as well as having multiple teams of reviewers associated with each submission, so they could work around the clock with the information provided and in collaboration with other leading regulators to ensure that every aspect of the review was looked at and decisions were taken in a timely fashion.
Thank you very much.
Thank you, Mr. Kellaway. Nous allons maintenant à Monsieur Thériault.
We will now move to Mr. Thériault. Mr. Thériault, go ahead. Thank you very much, Mr. Chair. I'm trying to understand, and I'm trying to put myself in the shoes of a taxpayer who's trying to understand how Canada was able to negotiate its vaccine procurement. Yesterday, in the case of Pfizer, the head of Pfizer said that there would be a third Pfizer dose necessary, most likely, after 6 to 12 months, and then a booster every year. You negotiated with Pfizer for a vaccine that was supposed to provide 95% protection with 2 doses. So how does that change the game? The introduction of that type of statement. Is it like ads on TV? Buy 2, get a third free? What is your reaction to that? Will the advisory committee study the scientific impact of that? And how does that change things in your negotiations? Because it does change the state of things. Are we not a little bit at the mercy of pharmaceutical companies that all of a sudden may take advantage of things to fill their order book? So Ms. Anand, and I'd like to hear from Nasi as well. What is the scientific impact of that, and what will you be doing? Because we don't know anything about your contracts or your negotiations.
Ça va coûter combien?
How much will that cost?
Est-ce que vous allez passer votre...
Will you be going for that third dose? There you go.
J'attends pour...
I'm waiting for my first dose right now. Of course. It's important to remember that we are going to follow the advice of Health Canada. So, what does Health Canada think? What are the instructions that you'll have in the face of such a significant change? That changes the game, no? Do you not agree that that changes things for procurement? Currently, we are negotiating with our suppliers to ensure, if necessary, we will have the flexibility in our contracts to purchase other doses. But it hasn't been finalized because we need direction from Health Canada beforehand. Minister, with all due respect, we have the impression that this flexibility is only on the government side. It's only from the purchaser's side because things have changed. It's gone from 2 doses to 3. And there are still studies being done on the time between the first and the second dose. So how does this change things with regard to other vaccines? Will you focus more on other types of vaccines rather than choosing one that will have a third dose and will be 3 times as expensive? What is your reaction to that? Thank you. I will answer, if I may. May I answer now? Yes. You may also answer in English because you seem to have difficulty elaborating in French. If the interpretation works well, it's good because your answers are a bit superficial, Minister. Go ahead. Thank you very much. I will speak French with you. Let's be clear. Science is always underway, and tests are still in their initial phases. But we are taking action. The first vaccines for COVID-19 were approved only 3 months ago. Okay, so you have nothing to say on that. Great. Now, for the Health Minister. The more difficulty we have vaccinating people, the more people die, the longer the crisis lasts, the more streamlining there has to be, and the more non-COVID patients are affected. The Association of Radiologists came to tell us that with the delays in diagnosing people, people will die. Non-COVID patients will die because we're not able to treat them in time. What will you do to address that?
Thank you, Mr. Chair, and thanks, MP Thériault, for the question. I think we've been quite clear that we'll be there for provinces and territories now and into the future to, first of all, get through this pandemic together. Regardless of what it takes, regardless of what it costs, the federal government will be there for Quebec and Quebecers, and we continue to be there financially, with equipment, with vaccines, and indeed with people. And after we managed to get the country in a more stable health situation, the Prime Minister has been clear that he is more than happy to have a conversation about what enhanced health transfers could look like at that point.
Excusez-moi, ça c'est
Excuse me, that's an intention, but concretely, would you like me to propose a solution, Minister? Would you like me to propose a solution? Okay, so let's transfer that $28 billion to Quebec and the provinces so that they can immediately deal with that offloading and know what their margin will be right away during this third wave that's beginning, rather than thinking we'll be able to fix this later, as if there was an after pandemic time. We're not even through the pandemic yet. And to get through the pandemic, well, that'll be when we deal with all of the non-COVID patients who weren't seen, who will be suffering from this pandemic. We're missing patients who need to be seen. Why not give Quebec and the provinces the funds they need to take care of patients now, right away?
Well, thank you, MP Thériault. And I'll say that this year alone, Quebec has received a direct transfer of $13 billion, $9.7 billion in health transfer dollars, $3.07 billion in the Safe Restart Agreement. We also deployed Canadian Red Cross. We've paid for and delivered 4.7 million rapid tests, over 2.8 million vaccines, 76 federal contact tracers, and the Prime Minister has been clear, MP Thériault.
That's not what we're talking about, Minister. Despite the ad hoc investments currently, what the provinces and territories need and Quebec needs is to be able to forecast the funds, to be able to take care of people, and to fix health systems. And for that, you need to do your part with health transfers. You know very well that it's $28 billion in addition to what's been invested on an ad hoc basis. Thank you, Mr. Thériault.
We're going now to Mr. Davies. Mr. Davies, go ahead. 6 minutes.
Thank you to the ministers for being here. Minister Haidu, as Minister of Health, are you the minister responsible for the Public Health Agency of Canada?
Yes, I am.
And from PHAC's website, it says that PHAC is Canada's lead agency responsible for public health, emergency preparedness and response, and infectious disease control and prevention. Is that your understanding of one of PHAC's mandates?
Yes, we obviously work with partners across government, but yes.
Thank you. And you are familiar with the concept of ministerial accountability, are you?
I would hope so, after 5 years.
Good. Well, on March 25th, the Auditor General tabled what I think can only be described as a scathing and comprehensive indictment of PHAC's preparedness for the COVID pandemic. I'm going to quote you from some of those reports, from that report. The report found that PHAC failed to test or update its readiness plans prior to the COVID-19 pandemic in direct violation of the agency's internal standards and recommendations stemming from the H1N1 pandemic. Minister, do you accept responsibility for that failure?
I accept responsibility for receiving the Auditor General's report, and I've been clear that we accept all the recommendations in the report.
Thank you. The Auditor General's report also found that PHAC failed to resolve shortcomings in Canada's health surveillance information and data systems, first identified by the Auditor General in 1999, 2002, and 2008. Minister, do you take responsibility for that failure?
I have been clear since the beginning of the pandemic and as a public health professional in my prior employment that it is very important that we invest not only in healthcare, but also in protection and promotion of health, which is public health. And I continue to say that we need to make those investments. In fact, that's why the fall economic statement commits hundreds of millions of dollars to bolster the capacity of the Public Health Agency of Canada.
Thank you. The Auditor General's report found that PHAC failed to assess the pandemic risk posed by COVID-19 or the potential impact were it to be introduced in Canada. As a result, the Auditor General found the agency underestimated the potential danger of COVID-19 and continued to assess the risk as low until after the World Health Organization had declared a global pandemic. By then, Canada had already recorded over 400 confirmed cases and community spread was underway. Minister, do you take responsibility for that failure?
Every step of the way, as you know, MP Davies, we have been guided by public health advice, science, and research, and we have responded to the pandemic with strengthened measures every step of the way. I have been clear, we accept all recommendations of the Auditor General, and I think no Canadian would argue with the need to invest in public health, and certainly that is the commitment of our government. We will ensure that the Public Health Agency of Canada has the funds and the resources they need to continue to strengthen their response.
The report also notes that GFIN, which was established in 1997 specifically to provide early warning of a threat such as the one posed by SARS-CoV-2, was not properly used when an outbreak of viral pneumonia in China was detected in late 2019 and early 2020. The report also documents that PHAC rescinded analysts' authority to issue alerts in 2018. Minister, do you take responsibility for that failure?
Well, as the member opposite knows, I was not the Minister of Health in 2018, and so it was a surprise to me as well when I heard the report in the Globe and Mail, which is why I ordered the independent investigation. And of course, we have an interim report from the independent investigators who have concluded that although the alert was not issued, it was, in fact, did not stop the beginning of our response, and that our response started very quickly as Dr. Tam had internal information and convened a committee on January 2nd of public health officers across the country.
The Auditor General's report found that PHAC failed to verify compliance with quarantine orders for 2/3 of incoming travelers and did not consistently refer travelers for follow-up who risked not complying. That did happen under your watch, Minister. Do you take responsibility for that failure?
Certainly, we've learned a lot through the process of working with our provincial and indeed local partners to strengthen enforcement of people that are required to quarantine as per the Quarantine Act. And I will say that we want to thank all of those partners for their ongoing and strengthened response. This is a Team Canada approach, and we need to work together at all levels to ensure that we're protecting the health of Canadians.
Minister, if you aren't responsible for PHAC's comprehensive failure to prepare for or effectively respond to the COVID-19 pandemic, who is?
No, MP Davies, I'd just like to take a moment to thank Dr. Tam, who's literally been working 7 days a week around the clock. And in fact, the thousands of PHAC employees that have been also working around the clock 7 days a week, doing their absolute best to respond to a global pandemic that is unprecedented. In fact, Canada's experience has been better than some countries and worse than others. But I will tell you this, we should be extremely proud and grateful for the hardworking Canadians that have put their life on the line and put their lives on pause to protect each other.
Thank you, Mr. Davies. That brings round one of questions to a close. We'll now start round two. My understanding is that the opposition parties have made some arrangements to switch around their time. So we will start round two with the NDP with 5 minutes, please. Go ahead.
Thank you. I'd like to direct my questions to Minister Anand. Minister Anand, when you appeared before the committee on February 5th, I asked you if you would disclose the confidentiality clauses contained in Canada's vaccine contracts. In response, you said, that's a very good question, and I will take that back to determine whether that would be possible within the confines of the parameters of the agreements. On February 17th, I followed up by sending you a letter requesting your timely response to that commitment. I have received no response to date. Given that you've had over 2 months to consider my request, will you or will you not table the confidentiality clauses in the vaccine contracts to this committee?
The confidentiality clauses are themselves contained in the contracts. The entire contract is subject to a confidentiality clause. Therefore, I am unable to table the confidentiality clauses alone. However, could I just continue, because I believe that our conversation the last time was about not only confidentiality clauses, but the contracts as a whole.
Actually, with respect, Minister, I have limited time, and it was a pretty specific question. So thank you for answering. I appreciate that. This week, BC's Health Minister Adrian Dix said the following: the real issue with vaccines is the amount of vaccines we have. If we could get 1 million more doses, we have the system in place. We have the capacity to deliver that quickly. Despite the unpredictability of deliveries, we are administering the Moderna vaccine as efficiently as supplies allow. Saskatchewan Premier Scott Moe says erratic deliveries are challenging his province's vaccination program. The City of Ottawa announced that it's looking to fill a gap in its COVID-19 vaccine supply. The City of Toronto announced that a vaccine shortage is to blame for the fact that local clinics in COVID-19 hotspots in the city have had to close. And Dr. Isaac Bogoch, who sits on Ontario's Vaccine Distribution Task Force, said, it's obvious we don't have enough supply. Minister, do we have enough vaccine supplies in this country right now?
In a very competitive global environment where all countries are seeking access to the precise same product, Canada has been able to procure vaccines despite the fact that we do not have at this time domestic production. In fact, we're the second in the G20 for the rate of vaccinations in terms of daily doses administered on the 7-day rolling average. We are fourth in the G20 for total doses administered for 100 people. We have much work to do. We have more doses to bring into this country, but we announced today, in fact, that we're doubling the number of Pfizer doses that are coming into the country in May and June. So we are working as hard as we can to bring more and more doses into the country, and it is indeed information that we make public to Canadians through the Public Health Agency of Canada as soon as we get it. We're all in this together. We're going to work with the provinces and territories so that all Canadians have access to a vaccine.
Well, the numbers I have, and I just checked them about an hour ago, as of April 16th, Canada is 41st in the world for doses per 100 people and 63rd in the world for people fully vaccinated. Are you content with those numbers, Minister Anand?
We clearly are looking at different numbers, but I'll tell you that my focus every day is getting more and more vaccines into this country. And as I said, we do stand fourth in the G20 for the total doses administered per 100 people, despite the fact that we don't have domestic production at the current time. There is more work to be done. We need to bring vaccines into this country as soon as possible. And Deputy Bill Matthews and I and our team every day work on this very issue. And as you can see from this morning's announcement, cumulatively, we're going to see between 48 and 50 million doses coming into the country prior to the end of June. Mm-hmm. And that is work that we're going to continue to do for Canadians.
Yeah, Minister, now the source of that is Our World in Data, which is what is being quoted by pretty much every reputable news organization in the Western world. Those are where those numbers come from. Major General Fortin, at your appearance before this committee on March 12th, I asked you if you were confident that all provinces and territories are prepared to rapidly administer vaccine doses as deliveries arrive in Canada. You said, provinces and territories have assured us that they have good plans in place and they have the health workforce required to scale up, so they have no issues with throughput. Right now, there's obviously a problem with vaccines in this country. Is that because the provinces aren't ready or because there's a lack of supply?
Mr. Chair, I stand by my previous comment. Provinces have been indicating that they have the resources, that they have the capacity, they have untapped capacity to increase the throughput. It's not equal across the board. It's not necessarily a mobile workforce that can get to all places in the country. And they've repeatedly asked for more line of sight on vaccine doses as they become available. And we endeavor to share with them as much as possible on quantities as we have that information.
Thank you, Major General. And who's responsible?
Thank you, Mr. Davies.
Thank you, Mr. Chair.
We go now to Dr. Pulaski. Dr. Pulaski, please go ahead, 5 minutes.
Yeah, I have to say I'm a little confused about the orders here, but anyhow, I wanted to talk about the risks associated with AstraZeneca and now Johnson & Johnson. I think a lot of Canadians are anxious about these vaccines and whether they're safe. So I did want to address that problem. Specifically, the concern is with something with blood clotting, but specifically one kind of blood clotting called VIPIT, vaccine-induced prothrombotic immune thrombocytopenia, which is associated with cerebral venous sinus thrombosis. It seems mostly in women under 55. Now, the risk of this from the United Kingdom, where they've given a lot of doses of AstraZeneca, has been estimated between 1 in 100,000 and 100 in 250,000. So, being a longtime doctor, medicine's all about balancing risks and benefits. So with that in mind, I wanted to talk about a little bit about the risks and benefits and get a response from the doctors on the panel, for example, Dr. Tam and the person from NACI. Now, my understanding of the British data is that up until the end of March, they've given over 20 million doses of AstraZeneca. There have been 79 cases of VIPIT with 19 deaths. And probably this is causal because this is a very rare combination. But as a result of those giving those vaccines, it's estimated that the British have saved around 6,000 lives. There's always a risk in medicine with almost anything. You think about an appendectomy. This is a relatively simple operation. I've done them myself. But if it's your kid, you say, okay, you have to have your appendix out. Well, the mortality is 1 in 100, approximately from my readings. Your gallbladder, taking that out, the risk is about 1 in 200. CAT scans, we do them all the time, and as a doctor, you have to explain to people the risks and benefits. And if your kid is getting a CAT scan, you tell them, well, we're not sure of the risk, but it might be something in the order of a risk of 1 in 2,000 people will get cancer from a CAT scan. Drugs, antibiotics. I've seen people almost die in reactions from antibiotics. And vaccines themselves, measles, for example, the measles vaccine has a risk of 1 in 700,000 of getting something called SSPE, subacute sclerosing panencephalitis, universally fatal. We give it to our kids all the time. My little baby you may have seen occasionally on the panel with me he's going to be getting it in a couple of months. So there's always a risk and benefit. No one's forcing people to have AstraZeneca or Johnson & Johnson. I have to say the risk in Johnson & Johnson seems to be 1 in a million. Before the practitioner, nurse, or doctor gives you the vaccine, AstraZeneca, they're going to explain the risks and benefits. And I would submit there's a very, very small risk from the vaccine. In fact, I calculated you're 7 times as likely to die in a car accident the year after you've been vaccinated with AstraZeneca than you are to die from a blood clot. So the risk is very low. The benefits in terms of protecting yourself from the virus are significant. So I wanted to ask Dr. Tam or the representative from NACI about the risks and benefits, and obviously I've outlined my view of it, but thanks.
Mr. Chair, thank you for asking me to be here today. So I'll take the question first. And I would say that Canadians should be very comforted in knowing that we have a very rigorous system in Canada for ensuring that the vaccine that they will get in their arms are safe as well as effective. So Health Canada, as the regulator, this very rigorous assessments of vaccine safety. And they've been linking with European and other international regulators to get the information that we need. And we acted fast when we saw that there was a signal from Europe. And with that, the National Advisory Committee on Immunization also took a initial assessment and a precautionary approach in having a pause in the use of the AstraZeneca vaccine in those persons under the age of 55. Right now, Health Canada, having asked the company, AstraZeneca, for more information, has done their assessment and analysis and concluded that the benefit outweighs any risk of this rare but serious adverse event overall. The National Advisory Committee on Immunization is doing its due diligence in analyzing this information right now. Now, what they have to do is not just analyze the risk of this rare side effect, but also the balance in the benefits of prevention of COVID-19 in different age groups. So they are doing this work very, very diligently right now, and will come out with their new reassessment soon, as Dr. Tunis had indicated. But again, I think that Canadians should be very heartened by the fact that our vaccine safety system and how we assess vaccine safety is extremely rigorous.
Thank you, Dr. Pawlowski and Dr. Tam. We need to go now to our next question slot, which is, I understand, Mr. Thériault. Monsieur Thériault, allez-y, s'il vous plaît.
Go ahead, Mr. Thériault, 5 minutes. Thank you. Thank you very much, Mr. Chair. To maintain confidence and trust from people in the face of public health messaging, we need to be consistent. As Dr. Tam was saying, we need to follow the precautionary principle. The last time we met, there were 3 countries that had decided to suspend vaccination with AstraZeneca. And so the agency told us, Health Canada told us, well, there are just 3. The rates aren't that bad. We'll continue. Since then, I don't know how many times comments have been made to try to reinstate the message on AstraZeneca, but if it had been suspended and a decision from the European agency had been awaited, we could have avoided all of those communication mishaps, those defensive messages, and we could have maintained trust because authorities had shown that they were proactive in applying the precautionary principle. In that sense, we ourselves, because we weren't proactive, because we didn't follow the precautionary principle, we undermined what we were trying to promote. So we did the opposite of what we wanted to do. And so now, people have fears about vaccination and about that vaccine. However, we've seen some enthusiasm in Quebec when we opened it up to those over 55 for walk-ins. But there had to be an advantage, and it was that it was walk-ins. Since then, it's gone down a lot, and vaccine centers are not full, even with the walk-in aspect. So we need to be careful because we may do the opposite of what we want to do. And that's important. It's a mistake that needs to be acknowledged. I'd like for Dr. Tam to explain to us how we can understand the variants currently. How is it that with everything we've done, all of the restrictions and the government's claims to be controlling things and having strict measures, how is it possible that we have so many variants currently? Do you have data on that so we can understand where the outbreaks are happening?
Mr. Chair, thank you for the member's question. Canada actually has been at quite the sort of high level compared to other countries in terms of doing our genomic sequencing and surveillance for variants. So we are sequencing a lot more virus than any other country, and we have been able to detect the variants and across Canada. And all provinces and territories are able to detect for themselves or access support from the National Microbiology Lab in order to do this. So we, I think we have actually quite a good visibility on where the variants are in this country. Variants, why we're concerned and why we call them variants of concern, because they spread more readily. And you have to be much more careful with your measures. But we do know that those public health measures do work. And we've seen it in the United Kingdom or Ireland or other countries that have had these variants of concern. So we know what to do all across Canada. And the important thing is that from local level up, things have to be applied rapidly, as quickly as possible, in order to control the spread. So the method is not different. You just have to be more stringent.
Dr. Tam, if I may, given that the borders are closed, that we have measures to control people coming in, we have screening and more, how do you explain the strength of the variants here in Canada? Do you have data that would allow you to understand what's happening in the main outbreak areas? What are the causes?
Yes, so in different areas of the country, there are different variants, but on the whole is the B117 variant that's present in all provinces. And I think there's only one jurisdiction that doesn't have that variant, but we have a good understanding that variant is becoming the predominant variant, and it is more easily transmitted. But again, more application of the same tried and true public health measures can get those rates down. So you've seen Quebec and Ontario and other places applying some of these measures right now, and that has been done very quickly. We do understand and have data from jurisdictions such as Ontario that some of these variants seem to be causing more severe outcomes, and you're seeing that in hospitalizations and ICU visits. So the data is there to track and look at the impact. But the really important thing is that this is, to me, you need to do this, what I would call the really important final go at suppressing the epidemic so that the vaccines can have time to work.
Thank you. Merci, Monsieur Thériault.
So you haven't identified the main causes of that contagion in the main outbreaks.
Merci, Monsieur Thériault. We go now to Ms. Sadhu. Ms. Sadhu, please go ahead, 5 minutes.
Thank you all the witnesses for being here with us today. Minister, you and your officials have been working nonstop for well over the past year to protect the health and safety of all Canadians. My first question is to Minister Anand. Can you tell the committee about the update we just received from Pfizer and how this will impact the government's vaccine procurement and distribution plans to provinces and territories?
Well, thank you so much for the question, and I'd be pleased to share the good news from Pfizer today. We have negotiated the exercise of an additional 8 million options with Pfizer. So that means that not only are we purchasing these options, but they're going to be delivered in the very short term. We expect to have 2 million doses of Pfizer delivered in May and 12 million per over 5 weeks in June. So 2 million per week in May, 12 million doses of Pfizer over 5 weeks in June. In addition to the other vaccines in our portfolio, this means that we are going to cumulatively have between 48 and 50 million vaccines in this country prior to the end of June. And I just want to reiterate that when we put our contracts into place last summer, and indeed our portfolio is a diversified one with multiple contracts and multiple suppliers, we wanted to make sure that we had access to multiple sources of supply of vaccine. So we are pulling vaccine now, not only from Pfizer, but also from Moderna, also from AstraZeneca, and also from J&J. And I think that that is what is very important. And if I could simply clarify a point about our rankings, I was speaking about the G20, where as I believe that my honorable colleague was speaking about all countries in the world. And we are indeed second in the G20 for the rate of vaccinations, fourth in the G20 for the total doses administered per 100 people. Why? Because of our diversified portfolio, because we're pulling in vaccine from multiple sources. And we will continue to do that and distribute those vaccines to the provinces and territories as soon as we receive those vaccines. Indeed, Pfizer's go directly to the provinces and territories as it currently stands. And make sure that we are with Canadians, supporting Canadians right through to the end of this pandemic with our vaccines. Thank you.
Thank you. Next questions to Minister Hajdu. Minister Hajdu, Peel has now more than 5,000 active cases. We keep hearing local concern that Peel region is not getting a sufficient supply from the provincial distribution stage for the number of cases. Yesterday, the mayor of Brampton had a discussion with the Prime Minister sharing these concerns. Today, he said that the government is ready. Even the Prime Minister said government is ready 24/7 to help Ontario if such help is requested. To either minister, I think Minister Hajdu, you can answer that. Peel Chief Medical Officers has similar concern. Can you explain who he can call about supply to Peel? How does this system work? And sufficient supply from the provincial distribution. What step our government is taking to assist hotspots like my home community in Brampton?
Well, thank you very much, MP Sidhu. And first of all, my heart goes out to everyone working in the Peel-Brampton area and everyone living in the Peel-Brampton area, because you're right. You have your region of the province has been very hard hit for, I would argue, a very long time. And the appropriate supports have not been in place to help people isolate and to stay safe. And although our federal government, as you know, has been trying very hard to make sure that people have access to, for example, financial supports if they're sick, other kinds of health supports through Red Cross support. And I work very closely, as you know, with Dr. Lowe, and we've provided isolation housing, for example, in your community. More needs to be done. You asked me first about how we can tell who's getting which vaccines, and we can't really. This is the job of the Ontario government to provide that transparency about how they are further distributing vaccines in the province and territory. And you heard my colleague speak about Pfizer being delivery going directly to provinces and territories. That's really the only data that we have. Data from other vaccines and how they're distributed across the province, that data is owned by the province, and they have not, as of yet, been transparent with that data. Although I do believe Dr. Brown, Steiny Brown, just recently gave some modeling and some updated data on vaccine distribution. The best approach in terms of trying to understand Peel's allocation of vaccinations from the province of Ontario is directly with the province themselves. And the mayor, Mayor Brown, would know that, but of course, Dr. Lowe would know that as well. And you're absolutely right. We stand by ready to help the province of Ontario and indeed local public health units with anything they need. If it would be helpful, I'm happy to speak with Dr. Lowe again, just to make sure that we haven't missed anything for the public health unit. As I said, we have been providing rapid response supports, including Red Cross workers, isolation housing, contact tracers, epidemiological support to breakout, where those clusters of outbreaks are happening, and of course the financial supports. It's very important they have someone like you, also MPs, to advocate for them. So thank you so much for being a constant voice for your community members. In every meeting I'm at, you are speaking out for the health and safety of the people that you care for.
Thank you, Ms. Sadu. We'll go now to Ms. Rumpel-Garner. Ms. Rumpel-Garner, please go ahead, 5 minutes.
Thank you. Major Fortin, how many doses of vaccine is Ontario projected to receive between now and the end of May?
Thank you, Mr. Chair, for the question. We are still crunching numbers with the new announcement of Pfizer, but with that increase, we'll have to come back to Ontario and issue those numbers and across Canadian provinces.
So back to you, Major General. Ontario just released information saying that they would need to vaccinate approximately 2 million people per week in order to have a hope of bending the curve by the end of May. Is that something that is possible given current projected supplies to Ontario?
Maybe I can take this question.
I directed it to Major General Fortin. Thank you.
Again, Mr. Chair, I'll have to do the number crunching with colleagues here before I can answer this question in detail. But the projections are that those numbers will increase for all provinces, including Ontario.
Would you be able to provide that data with committee perhaps by the end of next week with regard to projected doses for Ontario by the end of May?
We'll take that on notice, Mr. Chair.
Thank you. According to, I guess, Major General Fortin, I'm not sure if this would be you or Mr. Stewart, but I think it's you. Has the government, perhaps I'll direct this to Mr. Stewart, has the government asked you to provide any advice to update allocations to provinces or any other group based on hotspots? Or is it, is it just still per capita?
Thank you for the question, Mr. Chair. Our current approach, as mentioned, is per capita.
Okay, and has the government asked you to look at revising that approach at all?
I have continually my team working on different ways to respond to the pandemic and so different strategies. It's just the phrasing of your question. I'm not sure what you mean, but we do work on this.
Are you actively looking right now at potentially updating advice on allocations of vaccine from per capita to any other criteria?
It would be very normal for us to do scenario planning like you're saying, yes.
When would that become public?
Well, this is internal work. That would be for ministers if this was of interest to them.
Can you table any documentation that you have on that with committee by the end of next week?
I'll look into what's appropriate to provide and the extent that it's advice that's able to be shared.
Thank you. According to CTV reports, Mr. Stewart, Toronto hospitals are reporting that as many as 20% of ICU COVID patients are pregnant women. The Society of Obstetricians and Gynecologists of Canada is asking government to prioritize women more than 20 weeks pregnant immediately because of heightened risks to them from COVID. Are you preparing any advice to prioritize for the government to advocate for prioritizing pregnant women for vaccination?
Well, my colleagues from Health Canada would be better placed, Mr. Chair, to respond to the question. Before any of the vaccines can be used by Danny and our team with the provinces in this way, they would have to be approved for use for that indication.
Thank you. I'll move to my next question. And I guess this would be to Mr. Stewart. The same data that I referenced earlier from Ontario that was just released actually while we were in this meeting showed that the R0 on the variants is considerably higher than the original strain, and that data is showing that our vaccination rate is failing to keep up with variant spread. According to your department's projections, how many Canadians would have to be vaccinated every week by to get ahead of the reproductive rate of variants by the end of May?
That's a complex question. I look forward to reading the report. We'll assess it and we'll try to work out, make sense of what they're saying.
So you don't have any information on that or projections right now?
Mr. Chair, I believe you just said that it has just been released and I myself have not read it.
So does the federal government have any advice like on comparing the R0 factors with variants against what the vaccination rate would be in order to, quote, bend the curve?
The measures, Mr. Chair, that are used to bend the curve are usually public health measures. With vaccination, they're not actually normally applied in that way. So I'd have to read the report to see why you're phrasing it this way.
Well, what do you mean vaccinations aren't used to bend the curve?
Well, maybe we can turn to Dr. Tam to speak about.
No, I direct the questions, Minister.
Well,
Mr. Stewart.
actually,
No, Mr. Stewart, you just said, Mr. Stewart,
Dr.
you just said that are not that you're not using vaccination rates in terms of like, of course, vaccinations bend the curve. Like, why would you say something like that?
What I did say was that public health measures have been what we're using to address the spread of COVID to date. And then you're referring to a report that I haven't read yet.
No,
so
let's talk about this for a second.
Placing me in a difficult place to try and respond to your question.
Is Health Canada not using vaccination rates in terms of projecting bending the curve?
Thank you, Ms. Rempel-Garner.
A point of order, Chair. I believe that you skipped my round in the last round.
No, I didn't. This is your round.
No, you skipped my round in the last round.
You traded off your first round to the NDP.
I get 2 rounds.
You traded off your second round to the Bloc Québécois.
No, I did not. The NDP gave their spot to the Bloc Québécois, so there was another CPC round. I was just assuming you were giving me my spot in the second round.
I did. You had 5. This is your second round. You see 5 minutes. Your time is up.
In the second round. So now we go to my round again in the third round, right?
Correct. Thank you. So we'll start now with the third round of questions with you, Ms. Rempel-Garner. 5 minutes, please. Go ahead.
I appreciate that. I'd like to go back to Mr. Stewart. Mr. Stewart, I need to understand this. So how are vaccination rates being calculated by Health Canada in terms of using that information to, quote, bend the curve? Like, I'm just curious, why did you say we're using public health measures? Are vaccinations not part of that? Are you referring to like lockdowns?
Public health measures are protections, like you're saying, restricting mobility and so on. So that has been what we've been using in this country to, as you quote, say, bend the curve. And that's what I was trying to say. That's been the approach we've been taking.
Why aren't we using vaccination rates?
Well, we are vaccinating people, and as has been talked about in this committee, it's a major endeavor and initiative of what we're up to. My colleague, Dr. Theresa Tam, is probably a better person to ask this particular question to,
I'm sticking with
Mr.
you.
Chair.
So thank you, Mr. Stewart. So earlier, I think it was last week, the Prime Minister said something to the effect of vaccinations on their own are not enough to keep us safe. And then Dr. Tam did say that vaccines aren't a panacea. Are you concerned at all, Mr. Stewart, that by like what you just said, that might actually cause questions in the Canadian public about vaccines? Like, can you just put on the record right now that vaccinations will bend the curve in Canada?
I think the question is better answered by my colleague, Dr. Tam.
But you're the head of Health Canada. Look, I'm not, like, in all seriousness, can you tell Canadians that once we've rolled out vaccines, that will help bend the curve?
What we find is that as each person gets vaccinated, the number of people in the community who are at risk of infection is better protected. The community becomes better protected as more people are vaccinated. And so therefore we expect the incidence of COVID will go down.
When do you think that the public health measures that you mentioned, like lockdown, you would advise for them to be lifted? Like, what work are you doing on that, and how do vaccinations play into that?
The Chief Public Health Officer of the Government of Canada gives us the advice on these kinds of issues, and she's here with us today. And so she might be more appropriate to direct these questions to, Mr. Chair.
I guess I'll just ask very, very quickly, like, Dr. Tam, do you stand by your statement that vaccines aren't a panacea?
Vaccines are a major contributor to how we're going to get out of this pandemic, but they are not the only thing that will do that. Right now, to get things under control fast, public health measures must come into play. So it's both. And then until many people in Canada are vaccinated, the vaccine is unlikely to help rapidly.
Thank you.
But
How many people, Dr. Tam,
incredible tool.
How many people need to be vaccinated in Canada by the end of May in order for us to bend the curve, quote, with the spread of variants?
So you've just defined numerous parameters that are at play. So the variance increases your RT, which means more people will have to be vaccinated depending on how that evolves. And really, as I say, it's the stringency of the public health measures themselves that's going to help bend this curve while the vaccines are taking hold. And so we do not know precisely how much vaccines reduce transmission.
Are you concerned that, like, without having some certainty or at least some information on this in the public about that like Canadians might not be getting the message on this? Like I want people to take vaccines, but like statements like vaccines aren't a panacea, or like, do you have concerns about when you say that as the Chief Public Health Officer that might like cause concern among Canadians, or say why bother?
I think many Canadians want to get vaccinated. You see them queuing up. Uptake's been very high in the priority groups. What I will tell you is that vaccines prevent you from dying and getting into the ICU.
Okay.
Really, really important.
Thank you. I just have one question with the time remaining for the head of, or the Deputy Minister of Procurement. Are any of the Pfizer doses that were announced today, are they manufactured in the US, or are they all going to be manufactured in the EU?
The supply arrangements we have in place, Mr. Chair, allow Canada to draw from multiple sources, but I'm not able to disclose at this time where the actual doses are coming from.
Why?
Security of supply.
Thank you, Ms. Rimple-Garner. We go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead, 5 minutes.
Thank you, Mr. Chair. You know, there's two words that I've heard that have really stood out for me, and that this is an unprecedented pandemic, and that the results as we go forward are unpredictable. So I see no value in having armchair critics who have no medical credentials second guess what has been done and can't be changed. The real value for Canadians is to provide constructive suggestions for consideration of people who are professionals. Mayor John Tory said you can't make vaccines out of thin air, and that is very true. And I'm disappointed that we didn't permit Minister Anand to finish her introductory comments, and I'm asking Minister Anand to do so with the balance of my time.
Go ahead, Minister, if you wish.
Sorry, thank you so much. I will. Start off at the end of my remarks. Thank you to the honourable member for asking me to continue. We began with our procurements and vaccines by building a diversified portfolio of vaccine candidates as soon as they began to show promise, signing agreements in principle with potential suppliers as early as July 2020. And
our goal was to put Canada in a solid position to obtain deliveries of doses as soon as vaccines were deemed safe and effective, and that is precisely what we have done. We've obtained access to over 400 million doses of potential vaccines from 8 different manufacturers, which gives Canada one of the most diversified portfolios in the world.
Giving Canadian security in what has been and continues to be an extremely volatile marketplace for vaccines. And it is thanks to this diverse portfolio that we are now seeing inoculations happening at record numbers happening across this country.
Pardon me, Minister, could you turn your camera on, please?
Oh, I'm so sorry. It is on. I'm just using my other screen to refer to my remarks because I was kicked out of my laptop, and so I had to revert to my iPad, and that's why you can't see me while I'm reviewing the remarks. But I can just stay on camera and speak to our procurements this way, if that's preferable. Thank you, Mr. Chair. And so it is as a result of this diverse portfolio that we have been able to bring into Canada record numbers of vaccines. Yes, we, of course, continue to understand that more supply is needed. And that's why our team and Deputy Matthews' team is continuing to work around the clock. The deal with Pfizer that we announced today is just one example of the type of work that we're doing. We have accelerated more than 22 million doses already to earlier quarters. And this deal with Pfizer today indicates that even more doses are being accelerated to next month, right? We're doubling the amount of Pfizer doses coming into the country next month and in June. So we'll continue this work. We'll continue to pull vaccine from multiple sources around the world, including from Europe, from Belgium, from Spain and Switzerland, from South Korea, from India, from the United States. And it is this diversified portfolio of vaccines that we will continue to lean on as we bring vaccines into this country. And in addition, I would just like to thank all colleagues around the table for their concern and work on ensuring that our country sees itself through this pandemic together. I think what we do need now more than ever is to collaborate together with provinces, with territories, and indeed as parliamentarians. Thank you so much for the question.
Thank you. How much time do I have, Mr. Chair?
You have about 30 seconds.
Okay, I'll direct this then to Minister Haiju. Health Canada, PHAC, and NACI have done a great job in providing regular updates to Canadians, but I think that many people still don't have a clear picture on who is responsible for each aspect of the vaccines. When we hear from the officials of Health Canada, PHAC, or NACI that our opposition colleagues make an assumption that they're not aligned. So I'm wondering if you can inform our colleagues here today how these various independent experts are working to keep Canada safe.
Well, thank you. And I don't think I have that much time given the clock, but I will just say that they are working indeed very closely together. Dr. Tam works very closely with NACI. NACI works very closely with Health Canada. And this advice evolves, as you know, MP Van Bynen, based on the science and research that accumulates on these vaccines. I want to thank everyone for doing that hard work. It certainly is giving a roadmap for Canadians and for provinces and territories to take that advice and then provide those vaccines across the country. And I would just like to say that I have a profound and deep respect for the scientists and researchers and doctors that are leading the way. And I would really encourage all members of Parliament to work together now. This is the time, if never before, it is the time now for a Team Canada approach and to support the hard work of our researchers and our doctors and to stop the fear mongering that is indeed harmful to Canadian safety.
Thank you, Mr. Van Bynen. We go now to Mr. Maguire. Mr. Maguire, please go ahead, 5 minutes.
Thank you, Mr. Chair. I just wanted to get some clarification here on some questions that I've been waiting to ask in regards to the communications around the government and some of the things that they've said about AstraZeneca and some of the vaccine issues. I'm wondering if they can just clarify the confusion that they've put out in people's minds in regards to the mixed messages that they've had in regards to the usage of AstraZeneca. First of all, not being able to use it for people over 65, then not being able to use it under 55. Can you clarify that, Madam Minister?
Well, it's a fairly simple concept, actually, MP Maguire. As science changes and as research evolves, and in fact, advice evolves. This is the nature of a scientific approach, is that we respond to the new information, we commit to transparency to Canadians, and we evolve our advice based on the research and science that we understand. NACI, as you know, is an independent advisory board that can actually provide advice to provinces and territories. Provinces and territories are, by the way, free to take that advice or not. And in fact, all provinces have accepted the advice of NACI in many different ways. And I am glad to see provinces and territories working so close with the regulatory bodies.
I'm just going to interrupt you, given my time, Madam Minister. I'm just going to interrupt you. Today in the National Post, there's an article here. It states officials mixed messaging. More than blood clot risks are undermining COVID vaccine rollout. A year plus into the pandemic, and we're still having world-class science and medicine undermined by inexplicably amateurish communications. How do you respond to that. This is just it's been very confusing for public, and I'm getting a lot of calls and backlash here in my constituency from people who don't want to use it. And I think I know we've seen a lot of doctors and others come out and say, yes, get your vaccines, but these messages are coming from the government. And so I guess I'm very concerned about that type of media that's coming, the mixed confusion that's coming from different parts of the government between procurement and health, for example.
Well, I think our government has been very clear that the risks of COVID-19 way outweigh any risks associated with vaccination. And that, secondly, we will be transparent with Canadians as information changes and evolves. I think we all have a duty, actually, MP McGuire, to help our constituents get access to credible information and not to foster fear and sow discontent and confusion. And I think it's very important that
confusion, then why are you coming out and saying that vaccines are not a panacea? I mean,
because they are not, Mr. McGuire, and in fact, we need to continue to protect each other through the vaccination process.
That's pretty confusing messaging right there,
Mr. McGuire. In fact,
point of order, Mr. Chair. The standing rules state that a member is able to ask the question and the witness is given the same amount of time to answer without interruption. If Mr. McGuire can't control himself, I'd ask the chair to enforce that rule.
My questions are very short, Mr. Chair, so I appreciate that. Don't you talk about what you're going to say and how you're going to affect the uptake on these things? I just don't understand the circumstances that Ms. Hadju and Ms. Tam have talked about, and so
Mr.
what
Chair,
do you
my
think?
name is
what
Hadju.
do you think you had you? Yes. Well, had you have done these things, we wouldn't be in the problem we're in today.
Oh, Mr. Chair, I appreciate the mocking of my last name. It's very appropriate at this time. Mr. Chair, I'll say this. It is appalling that we see Conservative members try to sow division and fear. In fact, what Dr. Tam first said is, in fact, what we see is an unprecedented demand for vaccination. Canadians around the country understand that vaccination will save their lives and will contribute to the safety of their community. And so it is important that we continue to support Canadians to get accurate information in culturally appropriate ways. And that's exactly what we have been doing, Mr. Chair, including, Mr. Chair, a $53 million fund for local community organizations to work with a variety of different underrepresented communities.
So you also said that the border measures don't work, that you shouldn't wear a mask, different things that you've said through communications over time. And, I just wanted to ask Ms. Anand a question here then too about the boosters. Pfizer's indicated very clearly in previous meetings, and I've asked the question about boosters a month or so ago and got no reply yet, that they would recommend still that the second shot is within 3 weeks. The government has gone to 16 weeks in the decision. So will we see boosters be necessary? It was the question that I asked before, and they didn't say they wouldn't be. Now they're saying that it's come out that they may need that. Is it because the efficacy of the drug between the 3 and 16 weeks diminishes that we would need a third booster sometime within 6 months or a year?
Okay, thanks for
answer that.
Yeah, thanks for the question. It's actually a question that relates to the spacing of doses, and I'm the procurement minister trying to get doses to this country. So I would ask my colleague, Dr. Tam, to take the question if she could.
Well, it was a government decision, if I could just interject, no respect to Dr. Tam, but the disrespect, but the situation is because of the timing.
Mr. McGuire, your time is up, I'm sorry, but we'll let Dr. Tam answer. Please go ahead, Doctor.
Yes, thank you for the question, Mr. Chair. I think that we have to look at the science and the data. No matter what the manufacturer says, I think we have to make contingencies for the need for further doses into year beyond this one. But we need to have the data to look at the vaccine effectiveness to see how people have responded to their first and second doses. And then we expect both Health Canada and the National Advisory Committee on Immunization to look at that data in order to provide that recommendation. It is too premature, I believe, to do that. And we have to do the epidemiologic studies, look at the variants, and then how vaccines may or may not need to be adjusted according to what is circulating at the time. Thank you.
Thank you, Doctor. We go now to Ms. O'Connell. Ms. O'Connell, please go ahead. 5 minutes, please.
Thank you, Mr. Chair. Thank you to all the witnesses for attending today. Boy, for the level of concern that the Conservatives brought up in having these witnesses here, the best they had in terms of questioning was mocking an individual's name, one of our colleagues' names. Pretty disappointing, but it's clear that Conservatives, after a decade of muzzling scientists and ignoring the Public Health Agency and ignoring experts, that ignorance is alive and well today when they don't even seem to understand the evolution of science and the evolution of data. But I guess here we are, and I'm just very thankful to all of you, the witnesses that are here to work on Canadians' behalf. So I want to actually get back to that Ontario modeling that was raised in the time that I have. In fact, Ms. Rempel-Gardner left out a very important part of that modeling that was just released, which was the fact that Ontario, for example, has said they would be capable to do about 150,000 vaccinations a day if they had the supply. But even in that modeling, even if they did 300,000 vaccinations a day, that the trajectory of cases was still on the rise. Therefore, as has been said by the minister and the doctors on the panel today, that vaccinations alone are an incredibly important tool for keeping Canadians safe. Dr. Tam said, vaccines prevent death and attendance in the ICU, but strong public health measures that if Conservatives were in power several weeks ago said open up, ignore science, ignore the experts, ignore the data, we wouldn't, even 300,000 vaccines a day in Ontario wouldn't have helped if Conservatives were in power making those decisions. So can we talk about, and including actually Prime Minister Boris Johnson in the UK, who have very high vaccination rates, have credited case counts to both, to vaccinations as well as public health measures. So I guess my question is, or if we can elaborate on, in regards to those strong public health measures in connection to vaccination rates and how that is going to help. And frankly, in a very important piece that hasn't been touched, I'm not surprised the Conservatives don't talk about it because it doesn't fit with their ill-conceived lack of science, data, conspiracy theory type of questioning. But in and around our healthcare workers, they are strained and stressed. And so it's not just about keeping Canadians safe and getting them vaccinations, but the enormous pressure we're seeing in our healthcare sector. So could the minister or a member of our team here talk about why the two measures have to go together hand in hand and why vaccinations are incredibly important and Canadians are committed to it, but also why the public health measures matter so much, especially for our public health care workers.
Well, maybe I can just start and turn to Dr. Tam for a couple minutes. I'll just say, well, thank you for acknowledging the hard work of the healthcare workers, because you're absolutely right. Vaccines save lives and they do stop the spread, but they are not the only solution. We also have to continue to work hard on disease control. And we see that with other diseases, quite frankly. We have very high rates of vaccination for many other diseases, but it does take hard work on both ends. The public health measures, protecting communities, preventing disease outbreaks, outbreak, and also making sure people are vaccinated. And it is an extremely powerful tool in the toolbox, but we also need other tools. And that includes, for example, safer workplaces, support financially to help people stay at home when they're sick, making sure that people feel that they have the appropriate access to healthcare. All of those kinds of things matter. And so thank you for thanking the healthcare workers, because you're right, not only is it hard for people when people get sick, but our healthcare system, as we can see in Ontario, is surging. And when we don't take strong measures to protect our healthcare system, even more people suffer and sacrifice. So I'll turn to Dr. Tam to talk a little bit more about the theory behind that.
Thank you. And I also need to examine the Ontario report, but it was very clearly stated in a soundbite, at least from that report, that a 6-week stay-at-home order with a vaccination rate of at least 100,000 doses a day is the only way to flatten the curve. That also demonstrates Ontario also has the same message, which is you need both right now. And the United Kingdom has shown that they are ahead of us. Of course, we look towards them for data, that despite a very high vaccination rate, they've kept up some very stringent public health measures and are relaxing them very, very cautiously. Israel is another country. We can model, or we've done a lot of modeling. We also look at the real life data. Israel has a high rate of vaccination. The moment that they relaxed a little bit in sort of between February and March, they had the resurgence. They had to push back down on the stringent public health measures a bit more while getting more people vaccinated. So that points us towards the kind of strategy that we're going to have to do. We, together with vaccines, is the only way to combat the variants. Thank you.
Thank you very much.
Thank you, Ms. O'Connell. Nous allons maintenant à Monsieur Thériault.
We move now to Mr. Thériault. Mr. Thériault, you have the floor. 2.5 minutes. Thank you, Mr. Chair. I'd like to address the Public Health Agency of Canada. Currently, if I've understood Dr. Tam's answers correctly, the deployment of vaccines is based on a per capita approach. You must have had discussions when vaccines arrived. There were outbreaks. There was a major one in Quebec City, for example. You must have had justifications for that per capita approach, and I'd like to hear what those reasons were.
Teresa, would you like to respond?
C'est long, Monsieur le Président. Vous arrêtez.
Mr. Chair, it's quite a long delay. I hope you've stopped the clock.
So, sorry. So the per capita allocation is, of course, a policy decision taken with the provinces and territories together. Partly is informed by the fact that the highest risk groups are based on age. So the oldest of our population are the most highest at risk. Even if we looked at all the other risk factors, as NACI did, the National Advisory Committee on Immunization, age still falls out as being the key. And also some of our very much equity, health equity impacted populations. So with all of those calculations, it still worked out that a per capita allocation was the most consensus way of moving forwards. However, I think it is important now that number of provinces, Ontario, Quebec, British Columbia, and others are targeting hotspots, that it is important to have a look at that data and see what that different strategy might do. And so, yes, these are some of the areas of technical analysis that needs to take place.
N'est-il pas, en fait, ce que je comprends.
What I've taken from your previous responses is that until the virus is eradicated from the planet even, until everyone's vaccinated and we have an immunity bubble here, the main way of fighting transmission is individual measures for public health. So as soon as people know that a vaccine's coming and they no longer adhere to public health measures, then we have a surge in contagion. Is that not true?
Right now, that's a very important message. So no matter whether you've received one dose or even for people who receive 2 doses in the midst of a third wave, it is very important that we protect ourselves through all those layers of public health measures. And public health locally will look at how they may apply other community-based public health measures to help plank that curve. As the vaccine uptake increases, though, I think that we will find it much easier to manage any of those outbreak and surges, and that layer of protection will increase over time, and that would be really helpful. Thank you.
Merci, Monsieur Thériault.
Thank you, Mr. Tidio.
Now to Mr. Davies. Mr. Davies, go ahead, 2.5 minutes, please.
Thank you. Minister Anand, as you're aware, both this committee and the House have ordered production of the vaccine contracts. Have you sent the unredacted vaccine contracts to the law clerk yet?
Thanks for the question. After our committee appearance or my committee appearance and the number of concerns that have been raised relating to wanting to see those contracts, I, of course, made sure to go back to our contracts, look at them.
Minister, it's a simple question. Have you sent them or not? I have 2.5 minutes. Yes or no, did you send them?
My apologies. Not yet.
Thank you. 2 days ago, you told the Standing Committee on Government Operations that the government is committed to spend up to $8 billion on vaccine contracts. What is the price per dose that Canada is paying for our vaccines, or what is the range?
The envelope, as you mentioned, is $8 billion, and the price per dose is covered by the confidentiality clauses in our agreements, as I have previously stated at this committee.
Okay, so you can tell us selectively the total amount of money we're paying, but you can't tell us details about it.
It's an interesting viewpoint, but incorrect. I am simply citing the $8 billion envelope figure that Treasury Board already released to committee.
Fair enough. Do we pay a premium, Minister, when we have to get extra doses like we just ordered for the Pfizer doses?
No, we do not.
Okay, thank you. Dr. Tam, what is Canada's national R0 number right now?
It's about 1.1 to 1.2, definitely above 1, which means the epidemic is growing. And in certain areas, it's even higher than that.
Right. Mr. Stewart, when you appeared before this committee on March 12th, I asked you to confirm the maximum number of vaccination doses per week we can administer in Canada nationally. You undertook to provide this committee with that information. It's now been 5 weeks and we haven't received it. Are you prepared to table those numbers with us today?
Mr. Chair, my apologies for that. We will follow up on that, member, and provide that. My apologies.
Thank you. Dr. Tam, are we preparing right now for a 4th wave in Canada?
I think we should always prepare ahead of time, but there is a way to prevent that. We all know what needs to happen, which is to drive the 3rd wave all the way down. But let's just say that until the majority of Canadians are vaccinated and reinforced with that 2nd dose, any rapid relaxation of public health measures can definitely lead to a resurgence.
Thank you, Mr. Davies. That brings round 3 to a close. We'll start round 4 with Mr. D'Entremont. Mr. D'Entremont, please go ahead, 5 minutes.
Thank you very much, Mr. Chair, and might as well kick off where my colleague just sort of finished up. Looking at 4th wave, we're out of control right now by the look of it in the 3rd wave. The 2nd wave wasn't done before we hit the 3rd wave. What does the modeling say on when the 4th wave might hit? And I would say that's probably to Dr. Tam.
Yeah, so as that's a great question, and the focus of everyone right now should be getting that 3rd wave all the way down. You've seen what happens when you 2/3 of the way down and relax things on the second wave. So if you can imagine the same thing happening on the way down and you relax before you got to the bottom, that's what's going to happen.
I mean, do we qualify ourselves as being out of control right now? Ontario is projecting somewhere close to 15,000 people. I would suggest that sounds a little out of control. We're great here in Eastern Canada, but if Ontario loses track of things, I think we're in a bit of trouble here.
The situation right now is very concerning, and some of the key indicators is not just that the case rate is escalating so fast with that RT that another member had already flagged, but the fact that it's the indicators such as hospitalizations and ICUs, and the fact that the Ontario modeling alone is projecting an overflow of that capacity soon. So that is extremely concerning, and jurisdictions need to apply those public health measures fast, and as we had previously talked about in our modeling.
If we talk about variants for a second, I mean, we're tracking typically three variants right now in Canada. Because of this uncertainty, because of the distance between the vaccinations, the possibility of a third booster shot, what are the chances of another variant showing itself up and causing us even more grief?
Well, I think that the virus is always undergoing evolution, and we're monitoring this not just in Canada, but around the world. So there is a distinct possibility for other variants to occur. Although the virus seems to be honing in on a couple of very key mutations that are common to a number of these variants. So we might be seeing that the virus settling down on some of those mutations. So we just have to keep track and doing all the mutation analysis, the screening, and the genomics analysis. And we may have to modify the vaccines accordingly. We will have to see about that.
Okay, and as we talk about vaccine supply, vaccines being available, I know that Minister Anand, you're going to have to be very busy in keeping track of these second dose and third doses and all that stuff. When might we be interested? When are we going to be seeing a domestically produced vaccine available here in Canada?
Well, thank you for the question. The Government of Canada has put $126 million into the NRC facility in Montreal and has an MOU with Novavax, which, if all goes well and materializes, there will be domestic production hopefully later this year.
So 6 months away-ish, if everything goes well.
This is not my portfolio, however. It's Francois-Philippe Champagne, so I defer to him in terms of the status of the negotiations on that front.
Well, my final question to Minister Haidju. When it comes to the issue of sort of the other pandemic that's going around, we had the radiologist in here last week talking about deferred tests and surgeries, almost 380,000 Canadians waiting for some kind of treatment. How are you dealing with your provinces, your colleagues? Is it a Canadian problem, or is it going to be pushed back onto the provinces?
Mr. Chair, I'm going to have to step away. So thank you so much for the opportunity to take the members' questions. I really appreciate it. Take care.
Thank you, Minister. I appreciate your time here. And I understand that Minister Haidju has to leave as well. So I would like to thank you as well for your time.
A quick answer there, just a little answer there.
Oh, I'll give you a quick answer. Absolutely, MP. Thank you very much. I'll just say, when you mentioned the other pandemic, I thought that for a moment you would be talking about the drug overdoses and crisis that has been going on in this country for so long.
All right,
we are working on that as well. Thank you very much, everyone. Have a great evening.
Thank you, ministers. So
maybe someone has an answer to that.
Mr. D'Antimo, your time is actually, I think, up. Although I think I gave you a little extra time. But if you want to if you can get an answer to that question, I'll certainly invite anyone who wishes to answer to do so.
Okay, thanks, folks.
Thank you, Mr. D'Antimo. We go now to Mr. Kellaway. Mr. Kellaway, please go ahead. 5 minutes.
Thank you, Chair. And my questions will be directed to Dr. Tam. And I had several questions, but I think I'll just focus on maybe one or two. So early on, Dr. Tam, when you started doing projections, you talked about some of the limitations of the data because the federal government wouldn't have the same kind of data as the provinces would. Have you been able to address some of the data gaps with the provinces and territories? Question one. And if not, why are these national modeling projections important? Oh, I think you may be on mute, Dr. Tam.
I apologize. Sorry, Mr. Chair. So I think the whole public health system and other systems need to work together to get the data from bottom up. Over $4 billion was provided to the provinces, which I was very happy about because it's not just about just asking for the data. You need the capacity on the ground to do that. And we have been able to, through the investments, if you like, being able to get more information to fill in some of those gaps. But it actually does need collaboration across not just public health data, but other research. And the modelers have been supported now by another huge investment in the modeling and academic modeling networks. And so they have to do a lot of research to gather those parameters to fill in their models. So as you've seen that those models and a collaboration, for example, with McMaster University with Simon Fraser. So I do believe that those are becoming much, increasingly, robust, although very complex.
Thank you very much. One of the benefits of asking questions later on in the session is that you get to hear a lot of great questions from a variety of folks on this panel to our witnesses. And one of the things that struck me was around vaccines. And I'm wondering if you can or other witnesses can chime in here. So we know that, and by the way, my mother is receiving her first vaccine today, age of 80, and I have to check on her in a few moments. But we talked about how important the vaccines are, and there are words such as panacea thrown out, things of that nature. Can you just walk through this for the Canadian public, the importance of the vaccine, and then the importance of the other measures? Because I think it's really important because, again, one of my first questions was around how we approached it from Atlantic Canada and how thank goodness it has worked to date, the importance of vaccines, but also the importance of measures. I wonder if you can just kind of walk through that whole I guess, process of the importance of vaccine, what that means, and of course the importance of the measures in collaboration with the vaccine.
Thank you for that question, and Mr. Chair, I think the member hit the nail on the head, which is these are layers of protection. So if you think of all these layers that you put on to protect yourself and those around you, I think that's how I would look at both public health measures as well as the vaccines. Let's go to the vaccines first. Vaccines, we have been incredibly fortunate to have a suite of vaccines that we would never imagine have been arriving so fast, that they're safe, and the vaccine effectiveness has been great. So for our mothers and our grandmothers, our grandparents, the vaccines have actually been very effective for the priority populations at the outset. Those in long-term care facilities in particular has been so effective in reducing cases, in reducing severity of illness, reducing the number of outbreaks in long-term care. That's the population that was most impacted at the start of this pandemic, and we're seeing the vaccines at work right there. And the provinces and territories are now readjusting their measures at those long-term care facilities, still with layers of protection, with the masking, with the hand hygienes, with the testing, screening as needed. And people are able to have more visitors, to see more of their family members. And so that's what vaccines are doing right now. And healthcare workers, based on some data from our provinces, are well protected even after that very important first dose. And so vaccines are definitely at work and doing well. So we just, as everybody has articulated, we need to ensure that people do roll up their sleeves when their turn comes. And so, but the vaccines, in particular at the moment when the population is just escalating in that protective layer of vaccines. Public health measures is extremely important when variants are around, which means that you need to get those cases down in your community in order to protect everybody. And so vaccines alone are not going to be able to do that, but vaccines do play a really key part. And I have to say that there's some very good early signals that not only do vaccines protect yourself against serious illness and deaths, but particularly some of the mRNA vaccines are demonstrating that you can probably cut down on that onward transmission as well. So we are continuously analyzing that data, but it's all really great news.
Thank you very much. How much time?
You're done. Thank you, Mr. Kilroy. Yes.
Thank you, Dr. Tam.
We go now to Mr. Dreeshen. Mr. Dreeshen, please go ahead. 5 minutes.
Well, thank you very much, Mr. Chair, and it's great for me to be back here to discuss something that's extremely important to all Canadians. One of the things that I heard a little bit earlier from Dr. Tam, she said that they look at the science and the data, and no matter what the manufacturer says, you make decisions based on that. And I was just curious, are we the only ones in the world that are capable of coming up with a detailed analysis of such a circumstance?
I would say that many countries in the world follow the same process.
So that means there are a number of countries in the world then that are delaying the 12 or the 21-day, 28-day to push it over to 4 months. Is that what is happening throughout the world?
Sorry, I misunderstood your question. I'll just clarify. The United Kingdom, for example, right at the outset, looked at a 12-week interval for all of the vaccines. And our National Advisory Committee on Immunization has been following not just that data, but also domestic data from BC and Quebec. We are leading a leader in the world, particularly in terms of the studies in those two provinces, at looking at that stretch interval. And so far, the vaccine effectiveness has been very high, even at that 12-week mark. We're monitoring that very carefully.
Okay, thank you. And that's great to know, because I'm sure the rest of the world will be waiting for us for the studies that we've done. Perhaps, what about the concept of mixing vaccines? Because there's a lot of people that are, they are thinking there's going to be a 4-month delay before their next one. They might have taken a Pfizer vaccine, but perhaps a Moderna one might show up earlier, or quite frankly, the way we've been seeing it, probably if you got a Moderna one, then the Pfizer one would be the one that would be more available. If we could magically get all of these vaccines, would we then be going back to the recommendations from the manufacturers down to the 21 and 28 days?
So thank you for that question. I would take that question as well. The National Advisory Committee on Immunization advised up to 4 months. But of course, that can be adapted based on the evolving data, but also supply.
Certainly, but the question I asked, though, was the mixing of vaccines. Of course, the mRNA ones, perhaps they could be mixed. I'm not sure when it comes to the second one or the booster shot that we're expecting later in the fall.
So the current recommendation is that your second dose in a 2-dose series should be with the same vaccine or from the same group or class of vaccines. So if you got an mRNA, you get the other mRNA. But there are studies right now. And in the United Kingdom, we're looking towards getting that data soon, we hope. And that would inform the Canadian strategy going forwards. But also there are dose mixing, if you like, a mix of different classes of vaccines in Canada that's also being studied, planned as well, being supported.
Okay, so it's good to know that, as you said, we were able to lead the world in expanding to the 4 months. It'd be great to know that we're able to take that information on the mixing of vaccines, because people are going to be very concerned about it. Now, I was had seen yesterday that Albert Bourla, the CEO of Pfizer, said that a third COVID vaccine dose is likely needed within 12 months. And I was just curious about what the procurement plans are as far as that is concerned. And is that 12 months from once we get the second dose, or is that 12 months from when the first dose was administered?
So maybe, Mr. Chair, I can start on the procurement aspects, and I'll maybe turn to health colleagues to talk about duration or interval of the third dose.
Well, certainly, and I am very interested in the health aspect of it, but yes, quickly go ahead on that.
Just, Canada has bought more doses than we need for each Canadian. So there is, those doses under contract as well as options for more. And obviously, as the science evolves, the vaccine manufacturers are working on potentially boosters, potentially improved vaccines or adjusted vaccines because of variants. And we have ongoing discussions with those companies about what the next round of buy might be.
Thank you. And again, I think the NIH has started testing a new COVID vaccine from Moderna designed to protect against the problematic variant first found in South Africa. Do you have any knowledge about how quickly that particular vaccine might be available?
We are in discussions with the companies around the next round of buying. I can't speak to the timelines required to get through regulatory approvals, et cetera, but I suspect my my health colleagues might be able to help there.
I'd be happy to hear from them.
Thank you, Mr. Dreeshen. We'll ask the health colleagues if they wish to respond to do so.
I'll just respond from the perspective of any regulatory submissions we would receive for a reformulated vaccine, be it for a booster or a second generation vaccine, would be subject to a rigorous review through the rolling review process, and we would attend to that rapidly.
So from that perspective, there would be no concern.
Thank you, Mr.
Oh, I'm sorry. Thank you.
Yeah. We'll go now to Dr. Pawlowski. Dr. Pawlowski, please go ahead. 5 minutes, please.
I actually wanted to ask a bit about the same thing, the interval between the first and second doses. Certainly a lot of people are concerned about the interval. I've certainly had healthcare people who are saying, look, we're high risk. Why are we only getting one dose? I've also had elderly people being concerned and saying we're supposed to have the same dose after 3 or 4 weeks. Why is it longer? Now, I think the evidence, certainly for AstraZeneca, seems to suggest it's better if you have a longer interval between doses, but also with both Pfizer and Moderna. My understanding, I haven't looked in the last few days, but the evidence was that starting at about 3 weeks, at least in young people, you had about 90% efficacy. And the evidence seemed to be from British Columbia, Quebec, Israel, and United Kingdom that at least for 2 months, you had pretty good immunity. Now, we have other vaccines where there's 2 doses where it's 6 months in between. We have reason to believe that immunity is going to last for the full 4 months. Okay, so for someone like me, no problem. I've had, as somebody who still works a bit in healthcare, I've had my first dose. I'm not going to have my next dose for 4 months. But the concern is more with the elderly. Because at least studies seem to suggest their immune response is poor. The initial data from Israel suggested that one shot wasn't protective, although that seems to have been reanalyzed, and it seemed to be, well, a lot of those people were getting infected in the first 2 weeks where no vaccine is going to work. So I want to ask the person from NACI what the current evidence is regarding the safety of that increased interval in elderly people and people who might otherwise be immunosuppressed, for example, people on chemotherapy. Thank you.
Thank you for the question, Mr. Chair. So the NACI has certainly been reviewing in detail all of this evidence. So emerging evidence on effectiveness in the elderly and also some immunosuppressed populations, as you mentioned. I think there are a few things that are important to establish. First is that there is no correlative protection established for protection against COVID-19 you're probably aware of. So many of these studies, the preprint studies on certain immunosuppressed or solid organ transplant populations are based on antibody measures and in some cases cellular responses, but not true effectiveness in the real world. So it's hard to bridge those data over to real world effectiveness. That's one thing the committee has advised us in their report. The second is with respect to the elderly. Much of the data that was reviewed by the committee early on in making their recommendations, in fact, came from long-term care settings and from the elderly. So if we look at their analysis of what's been reported from the United Kingdom, where they were using an extended 12-week interval, for example, they found very good protection, very good effectiveness against severe outcomes. So hospitalization and death, certainly above 80%. The effectiveness against symptomatic disease is lower, and we're seeing that reported. But the most critical outcomes are being very well protected. And looking to Canada, the committee was reviewing presentations, as Dr. Tam mentioned, from Quebec and British Columbia. Both provinces, by the way, are doing weekly vaccine effectiveness monitoring, so they're keeping a very close touch on how this is evolving, and that's being fed back to NACI and the provinces and territories. And we've seen in the range of 80 to 90% effectiveness in the long-term care setting in those jurisdictions, not only against severe outcomes, but actually against PCR-confirmed COVID-19 infections. So it's a very strong evidence base at this point, understanding it's not out to 16 weeks, but as Dr. Tim mentioned, we're getting up to the 10, 12-week mark in Canada with no signs of deterioration, even in those elderly populations. So the committee is watching carefully, but at this time was very comfortable to say that up to 4 months could be considered by jurisdictions, understanding that they may choose to shorten it for specific populations based on their epidemiological context. Thank you.
Quick question for Dr. Lucas. Health Canada's approval of monoclonal antibody combinations, specifically the Eli Lilly bamlifimab estivimab combination and Regeneron. Those applications for approval have been there since February. Growing evidence suggesting that they're quite effective in preventing progress to severe disease. Obviously, our ICUs are overflowing. The NIH is recommending, because of the American variants, that we use these in Canada, at least in Ontario. Bamlifimab alone seems to would cover 90 to 92% of the variants in Ontario. When can we expect to hear something from Health Canada on these other monoclonal antibodies, and can it be expedited given the situation, particularly in Ontario?
Thank you, Mr. Chair. As the member noted, both the combination therapy involving bamlanivimab of Eli Lilly and Regeneron from Roche are before Health Canada, the regulator. The submissions were received in February and are undergoing the expedited review process that I spoke of earlier under interim order. I can't say when they will be approved, but the scientists are working day and night to review the submissions.
Thank you, Dr. Pawlowski. We go now to, nous allons maintenant, Monsieur Thériault.
We now move to Mr. Thériault. Mr. Thériault, go ahead. 2.5 minutes, please. Thank you, Mr. Chair. Dr. Tam, in response to questions that I asked here at the committee, you recognized before the committee, and it's to your credit, that with hindsight, you said you waited much too long to recommend the closing of the border with the United States. With all due respect for jurisdiction, but with the knowledge you had of the situation in Quebec and Ontario, what is your opinion of a possible closing of the border between Ontario and Quebec?
So I have, of course, at a technical level, discussions amongst the chief medical officers of health, and that's to facilitate the discussions between the provinces. Interprovincial travel and indeed intra-provincial travel is in the jurisdiction, but I have been happy to support some of the deliberations, but it is actually up to Ontario and Quebec.
Mais vous n'avez pas d'avis.
But you don't have any scientific guidance on that? Or you prefer to let them make their own decision? I was curious to hear what your analysis of the situation is, but it's okay if you don't have a specific answer. But if not, go quickly, please.
Well, the virus is transmitted human to human. So any measures that reduces mobility and in order to control a third wave is something that provinces can consider.
Vous exercez à la...
At the agency and with other institutions in Quebec and Ontario, you have a decentralized coordination, so there's some fluidity. The Auditor General noted some gaps in exchange of data. So what have you done to improve that situation specifically? Dr. Tam.
As I've said earlier, the public health system is under stress. So even though it was a will to provide the information, we were not getting everything that we had agreed to, really, with provinces and territories. But I think I was very happy to see the support of over $4 billion provided to the provinces. We do have another refresh of the expectations of what's to be collected at the national level, including race information and occupation, such as whether a case is a healthcare worker or not. And that data collection has improved over time. We've got a little bit of ways to go, but that is improving. And we also have already started on a pan-Canadian health data strategy and also established a cloud-based data sharing platform to assist in a more timely and more efficient way of collecting the information.
Merci, Monsieur Thériault.
Thank you, Mr. Thériault. Thank you. I'm out of time.
We'll go now to Mr. Davies. Mr. Davies, please go ahead. 2.5 minutes, please.
Thank you. Mr. Matthews, or I don't know if it's Dr. Matthews, did Canada pay more or less for our vaccines than the US did per dose?
I can't answer that question, Mr. Chair, because the nature of the agreements is confidential. And the U.S. arrangement, remember, in many of its situations, the government actually invested in the companies themselves. So you can't do a dose-per-dose comparison.
Okay. Dr. Tam, given that Brazil is currently running such an extremely high case rate, are you concerned that it could be a crucible for an ultra-infectious or vaccine-resistant variant? And if so, can you explain why the federal government quietly dropped specific screening requirements for travelers arriving from Brazil this week?
Well, I think the situation in Brazil is something that it is of international significance, and countries, including Canada, I think, needs to participate in multilateral discussions as to how that can be assisted in terms of Brazil's really tragic situation. And some of it might be sharing expertise, but there's other measures as well. Now, we have instituted many layers of border health protection over time. And that includes, as you probably aware, a series of testing, including pre-departure and 2 post-arrival tests, as well as the 14-day quarantine period stays, and including awaiting test results from a GAA. Very stringent measures are being applied by the quarantine team in terms of a quarantine plan. So,
Dr.
so
Tam,
those
wouldn't
are
it
the
be,
really
could I
key
just
layers.
ask you, wouldn't it be prudent to keep those extra screening requirements? What's the benefit of dropping them?
Well, in fact, I think every country is, the stringent measures are being applied to every country. And I think that was reassessed because the number of arrivals from Brazil is in fact pretty low, and the same stringent measures. By the way, the P1 variant is found in over 40, maybe 50 countries by now. So you can't just focus on Brazil.
So Major General Fortin, just a quick question. I want to be clear. We know that there's thousands of vaccine appointments are being canceled across the country. Everybody's saying it's a lack of supply. From your perspective, is the problem right now in Canada a supply bottleneck, lack of supply, or is it a capacity issue by the provinces to vaccinate?
Thank you, Mr. Chair. Provinces indicate that they would require more supply to scale up. Clearly, there are jurisdictions that don't book appointments until they have certainty on shipments. So that avoids them having to cancel appointments when they see a delay in shipments. Others choose another option. All options work. It's a matter of risk management, and it's really is a responsibility of those jurisdictions.
Thank you.
Thank you, Mr. Davies. So that brings question round 4 to a close. I believe we'll have time for a shortened 5th round if it's the will of the committee to do so. I would suggest we have 3-minute rounds for the 3-minute slots for the Conservatives and the Liberals, and 1.5 for the Bloc and NDP. Is that acceptable to everybody? Seeing no head shaking, I will say I will go ahead on that basis. Ms. Rempel-Garner, I believe it's over to you for 3 minutes.
Yeah, thank you, Chair. This question is for Mr. Matthews, and it builds on my colleague Don Davies' questions. In an email that was just released to the Health of Commons Committee in a document dump per one of the motions we had in the House of Commons, it's from a RIC thesis on September 24th, 2020. And it states that on AstraZeneca, folks are reviewing a final MOU right now. Basics are 20 million doses, delivery to start in Q2, early Q3, and all doses by end of 2021. The price per dose is $8.18. Mr. Matthews, why did Canada pay almost double the price of any other country for the AstraZeneca vaccine?
I'm not sure what you're using as a comparative figure, Mr. Chair, in this case, so I'd have to get back.
The European Union paid $2.15 a dose, the United Kingdom $3, and the US $4. So why did we pay double the amount that the US did?
So a couple of things here, Mr. Chair. Number one, location of manufacturing is important in terms of considering price. And as I mentioned before, the US in particular had some investments in the companies. The rest I can't speak to except for the EU. Just remember that there are two prices in the EU. There's the price paid.
$8.18 for
I'd actually have to go back and check that. I haven't seen that email. I apologize. But I just, for members, Mr. Chair, I think on the EU front, worth noting there's a two cost component here, the price paid by the member state as well as the EU itself.
Just for facts for reporting tonight. So we did pay $8.18 a dose for AstraZeneca.
I'd have to go back and confirm that.
So you said that that parliamentarians can't look at the price per dose of vaccines, but now you're commenting on it. So when are you going to release the price per dose to this committee?
So a couple of things here, Mr. Chair. Number one, the contracts are confidential, and
So when do I get the price per dose for everything else?
So, Mr. Chair, if I could finish on this one, I'm very reluctant to effectively be in breach of a contract while we're in a world of, competition for doses and negotiating next round of buys. So, I can't speak to this email. I haven't seen it.
Why did we pay double? Why did we pay double for this?
I can't confirm the doubling, but I can tell you that
because we came late to the table for negotiating, so we had to pay a higher dose price per premium. Is that why we paid higher?
I think the only thing I can offer here, Mr. Chair, is the location of manufacturing is an important consideration in terms of the price discussions across the board. So I'm not commenting specifically on AstraZeneca, and I can't comment on the suggestion that it's double.
I'll keep going.
Well, actually, your time is now up. Thank you, Ms. Rempel-Garner. We will go now to Ms. Sidhu. Ms. Sidhu, go ahead. 3 minutes, please.
Thank you, Mr. Chair. Dr. Tam, earlier this week, your Deputy Chief Public Health Officer, Dr. New, provided a clear answer from a conservative colleagues' questions. Can you clarify what other tools such as masks and physical distancing are necessary while we vaccine Canadians? Can you clarify why wearing masks continue to be necessary?
Yes, so the basic immunity in the population is still very low based on our serologic surveys, for example. And vaccines are only just getting going while there is a significant resurgence of cases. So every person in Canada needs to layer up the layers of protection. the masks are important because the way that the virus can spread is through these droplets and aerosols that can be generated and when someone's infected. And secondly, of course, the distancing when you're not within people with your household. And there are many celebrations that people want to have, but do that virtually because it is that closeness between individuals infected and the uninfected that helps the virus transmit. But also, avoid the 3 C's, the closed, crowded environments where there is close interaction between people, as well as, of course, hand washing and hand hygiene measures. Those I think are the basic individual measures that are very important. And of course, respect your local public health unit's advice about what to do in your community.
Can you also speak to what you're doing to increase uptake among multicultural communities for those who may experience issues with the registration because of language barrier?
Yes, of course, the provinces and territories are responsible for the delivery of the vaccine programs, but I think that the federal government can help in many ways. Of course, providing credible information in multiple languages is really key. That's one investment. But we have been quite excited about investment in community-based projects where people can apply for funding so they can use that fund to communicate the credible information to their communities, whether they're faith leaders, whether business leaders, who can speak the language and can do the outreach to others. And I've been very fortunate to be able to participate in some of those events with business leaders, but also with Black physicians, for example, and Black North, public and private sort of sector collaboration to reach those hard to reach populations. So also giving the tools that healthcare workers who are trusted by their communities, family physicians and others, the tools to be able to answer those questions that their communities might have. In the end, it's about access as well. So helping where we can, supporting the provinces if needed, to mobilize to areas where some of the increased access is required, such as Major Danny Fortin and the Canadian Armed Forces helping in certain Indigenous communities in getting the vaccine into their communities. But in the end, it's the people and the leadership in those communities, like the elders vaccinated and communicating about this, that has really, really helped. And the vaccine uptake has been great in those communities. Thank you.
Thank you, Ms. Sadu. So we go back now to the Conservatives. I'm not sure who's up for the Conservatives on this round.
I'll go again.
Go ahead, 3 minutes.
Dr. Matthews, why did Canada pay so much of a premium? I certainly think that for other countries, production capacity on all the factors that you mentioned would also play. It would be a common denominator. So why did Canada pay a premium for the AstraZeneca vaccine compared to other countries?
So thank you, Chair. A couple of points. First of all, there's no doctor here, so just to correct the record on that front. On price per dose, you can't compare country to country because other countries actually invested directly with the manufacturers. So, and again, I don't have specifics, but it's not as simple as that. You've got UK and US manufacturing occurring. Location of manufacturing is a factor. I would imagine volume might be a factor as well.
Matthews, did we know what the other countries were paying when we negotiated our contract with AstraZeneca?
At that time, no. All the contracts were confidential, and many of them still continue to be confidential.
So then, how do you know if those factors played a role in us paying a premium?
So, number one, in discussions with AstraZeneca, we talked about locations. The volume issue, I'm speculating a bit, but just based on experience in procurement, it matters. I can't say specifically in AZ, but the size of the order certainly matters.
If you didn't know what other countries were paying, you just kind of accepted $8.18 a dose.
So we were in a world, same story as PPE is with vaccines. These are effectively a short commodity that, great competition for. So essentially you negotiate as best you can, but, certainly a seller's market, and it continues to be so in the vaccine market. So
with the seller's market, did we pay a premium because we were late to the table? Do you think that or we signed contracts after other countries did? Do you think that had anything to do with it?
No, I wouldn't accept that at all, Mr. Chair. In fact, in many cases, Canada was, one of the first countries negotiating. So that's never been brought up as a factor.
So how come we paid so much more if we were one of the first countries? And how did $8.18 come to be? Like, how did you guys agree to that?
So, Mr. Chair, I can't, again, comment on the comparability because when you have governments investing directly in the manufacturing, like the UK and like the US, I'm not sure I can make that comparison.
Domestic manufacturing capacity for adenovirus-based platform vaccines led to a higher premium with the AstraZeneca vaccine?
No, Mr. Chair, that's not what I'm saying. What I'm saying is governments who actually subsidize the manufacturing vaccines, you end up with a different deal where you're actually
providing no subsidies to AstraZeneca whatsoever.
So AstraZeneca is not manufactured in Canada, so that we're dealing with a straight price per dose model here as opposed to a broader manufacturing discussion.
Okay, and Mr. Matthews, were there any other factors that contributed to the $8.18 a dose? Did we pay a premium for every other vaccine as well too?
So again, Mr. Chair, I'm not accepting the comparison simply because I can't speak to whether there's a premium here or not. But I can tell you that negotiated in good faith with all suppliers, and again, it was definitely a seller's market.
Thank you, Ms. Rempel-Garner. Go now to Mr. Van Bynen. 3 minutes, please. Mr. Van Bynen, you're muted.
Perhaps that was just as well. I'll start off by saying hello. We're in a pandemic. We're in the third wave. We need to get medicine in people's hands, and we've got some vaccine hesitancy around the AstraZeneca lately. And some of this has been fueled by our opposition members, and we've seen some examples of those questions again today. So I would ask Dr. Tam, what can you or your officials share about AstraZeneca vaccine to reduce hesitancy? Let's focus on the immediate issue. Get people well, keep people well. How can we go about doing that?
Yes, as I've previously mentioned, the vaccines, we are really, really fortunate to have them, and they've been performing very well, particularly all vaccines in Canada, AstraZeneca included, are really effective at reducing severe outcomes, hospitalizations, and deaths. That's really important, particularly for older populations who are at higher risk. And so I think that is why everybody should get vaccinated. We have even a bit of early signal that, of course, if you have highly effective vaccines, you cut down on the number of infected people, asymptomatic or symptomatic, there is a good chance that you will reduce transmission. So that is some of the initial data that we've been really looking forward to. So that's also good news. But vaccines alone can't sort of reduce transmission right now when there's such a huge amount of force on this from this virus in this third wave. So just keep up with those personal protective measures and roll up your sleeves, because with all of these discussions, all I can say is that be rest assured that the Canadian regulators and our expert committees are paying their due diligence in providing the advice according to data. But in the end, please roll your sleeves, because whatever you get in your clinic and being offered to you are safe and effective vaccines.
Great. This is a good segue. I've heard people talking about vaccine monitoring when asked about what happens if someone has a reaction to a vaccine. Can you tell us more about Canada's vaccine monitoring system and how that works once a vaccine is approved for use in Canada?
Yes. So, and Deputy Lucas has part of this because the regulators in Health Canada, even though they've authorized a vaccine, and they continue to have a role in monitoring the safety post-marketing. And the manufacturers are also being asked to provide data on this on an ongoing basis. So that's one stream. The public health system that is administering the vaccine, or the health system that's administering vaccine, also provides their data on any adverse events following immunization through the Canadian Adverse Events Surveillance System, which comes to the Public Health Agency. The data is published on our website, and we share this with Health Canada as well. And so any serious or unusual events are reviewed from medical experts, and that is being taken very seriously, which is why, for example, just very recently, given the signal of the thrombosis with low platelet event, the whole system had been activated, and one report was picked up from Quebec. So that's one, but it's reassuring that the system is actually working in monitoring that safety signal. And so that is really important. And then we have active surveillance systems. There are hospital networks that are engaged in actively searching out for cases that may be adverse events following immunization, so that those can be investigated. And there are specialty clinics set up as networks where patients who may have experienced an adverse event following immunization can receive specialist advice that is needed to sort out whether that is indeed something that's related to the vaccine. So it is actually a multi-layered, interconnected system. And that's why I think Canadians should rest assured that anything unusual, any signals will get investigated.
Thank you.
Thank you, Mr. Van Bynen. We go now to, nous allons maintenant, Monsieur Thériault.
We go now to Mr. Thériault. Mr. Thériault, go ahead, 1.5 minutes. With Pfizer, have you had communication on the third dose necessary 6 to 12 months later? Thank you for the question, Mr. Chair. I would say that at the beginning, we didn't know how long the vaccine would last. So we had a contract for 2 doses per person. We still have options with Pfizer, and as I said earlier, we've begun discussions with the supplier about the possibility of purchasing the next version of their vaccine boosters and things like that. Do you have the impression that you were had in the negotiations? Because I imagine that a company arrives, promotes a vaccine that has 2 doses, and then you learn that there's a third dose that would be necessary. We can understand the booster, but it's not the same information. Do you feel that you were had? We have to remember that at that time, when we were negotiating the contract, we didn't know which vaccines would work. That was unknown. So we negotiated based on the science and the data we had at that time. And data has continued to develop. So Pfizer has just indicated regarding the vaccine that maybe we need to add something. Did you request scientific advice on the need? Are you going to ask Mr. Stewart to ask NACI to evaluate this, to conduct a scientific analysis of that need before you renegotiate with Pfizer on whether there should be a third dose? So we could buy a number of doses, or perhaps we could have a contract for the next version of the vaccine. We continue to hold discussions about this. As Mr. Lucas already said, if there are changes to the product, we have to submit something to Health Canada to receive their approval. But before going forward, will you ask for scientific guidance on the need? Will you ask for that?
Monsieur le Président.
Thank you.
Mr. Chair.
We'll go now.
I'd like to have a little answer, yes or no. Are you going to ask for scientific guidance, yes or no? Yes or no? Will you be asking for one? Mr. Chair, will you request scientific guidance? It's just a question, Mr. Chair, that we have a hard time understanding each other and there are delays, so I need more time. Yes or no? Would you ask for advice? What I can add is that we need to submit the documents to Health Canada for the next rounds of products. Thank you.
Great. Thank you, Mr. Thériault. Mr. Davies, we'll go to you. We'll give you a little bit extra time as well. Go ahead. a minute. Well, go ahead, a minute and a half, and we'll give you a little extra time.
Thank you, Mr. Chair. Dr. Tam, 1 week ago, you issued a statement that said the following: the Government of Canada's longer range forecast predicts a strong resurgence in the absence of enhanced public health and individual measures. 2 weeks later, this strong resurgence is showing in national surveillance data we are seeing now. National case counts are plodding along the strong resurgence trajectory of the March 26th forecast. This clearly shows that we need stronger control to combat variants of concern that are driving rapid epidemic growth in many areas of the country. What specifically, Dr. Tam, are those stronger control measures that we need to take into, that we need to put into practice in this country?
Thank you for that question. And yeah, it was when the modeling was done, people were a bit sort of concerned about that trajectory, and we're plotting against that. So the measures are to reduce social mixing through whichever means is appropriate for that community, whether it's Toronto or whether it's Montreal, it might be a bit different. But some of those measures you've seen the provinces put together now in reducing workplace transmissions. Ontario's decided that, people should follow essentially staying at home, only mixing with your household, and only going out for essential activities. And so all of those things are really important. At the same time, I certainly believe that outdoor spaces are safer and that you can go out more safely and keep healthy and physically active, and it's good for your mental health. That's particularly if you stick to your household, like in Ontario. So those are the tried and true measures. They have worked. If you looked at the United Kingdom and that massive spike, all of those measures have helped them for sure.
But if I might, Dr. I mean, we've been hearing those same measures from the beginning. We're in a third wave. The numbers are higher than they've ever been. So what is it that we have to do differently?
Well, I think the criticality of that modeling was that you can't relax. I think provinces know how to get clamped down on those cases. They've done it before, but you have to be really careful now on the way down not to relax them too quickly as well. So, and any relaxation must be done very thoughtfully and carefully in stages. And so I think they are trying, but it's the same measures, but less room for any sort of, stringency.
Is it time to maybe look at interprovincial travel restrictions, do you think? I know Atlantic Canada had great success early on. Is it time for us to start looking at that?
Well, the Atlantic area as well as the territories have actually done this. And as I've said, it is a provincial matter, but it is, and I'm happy to support those discussions with the other chief medical officers of health. But anything that reduces mobility, whether it's actually in between regions of the province as well as between different provinces, can be considered by them. But I also know that it's easier said than done because of the necessity to access services, essential services, for example, on either side of those borders. So it's not for me to sort of get into that space. But one actual message that I did put out there is that you should avoid non-essential or recreational or vacationing in someone else's province right now. Of course, there's reactions to that, but that's what the chief medical officers have come down to, is that, can I please message this across the country? Now's not the time to go skiing in British Columbia. And that is really important to follow as well.
Thank you. Thank you, Mr. Chair, for the extra time. I appreciate that.
Thank you, Mr. Davies, and thank you, Dr. Tam. Thank you, in fact, to all the witnesses. It's really appreciated that you could spend your time with us today and give us your advantage of your expertise and your knowledge. And thank you for what you do on a day-by-day basis, 24/7. And if there is no further business by the committee, I think that we will adjourn. So we are now adjourned. Thank you.